Welcome to everyone for this our first virtual uh, conference, and I'm extremely thankful to all the speakers. They have agreed in a very short notice and a very short time to come up and, of course, contribute their best presentations with us. So I invite Dr. Sultan to say a few words as president of APPNA and inaugurate the conference. Dr. Safdar.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam. Bismillahir Rahmanir Rahim. Assalamu alaikum, everyone, and a very warm welcome to everyone joining us today from across Pakistan, North America, the Middle East, the Europe, and beyond. And it is truly an honor and a privilege to stand before you, even if virtually, to inaugurate the first virtual neonatal conference organized jointly by APPNA Peds and academic neonatal community of Pakistan. Honestly, let me start by saying this clearly. Today is not just another Zoom meeting. Today is a milestone. If you had told us a few years ago, that neonatologists from different continents would gather seamlessly on platform to learn, to teach, debate, collaborate in real time, we might have simply smiled and said, Inshallah. Well, Alhamdulillah, Inshallah has arrived. I often joke that neonatologists as professions, defines by minimal sleep, maximum caffeine, and still make life-changing decisions in seconds. Now we have learned something new. We learned how to master Zoom technology. On a serious note, what brings us together today is something far deeper than technology, and it is a shared commitment to newborns who cannot speak for themselves, a shared responsibility to improve outcomes where resources are limited, and a shared belief that collaboration beats isolation every single time. And let me repeat that. A shared belief that collaboration beats isolation every single time. And as a president of APPNA Peds, I firmly believe that true progress in neonatal and pediatric care does not come from isolated excellence. It comes from connected excellence. From sharing knowledge across borders, from learning from each other's successes and failures, and from creating platforms where experience from high resource settings, like innovations, and from resource limited settings inform each other like we are doing today. And that is exactly what this conference represents. And today's program reflects that vision beautifully. For example, we have topics covering from hypothermia in low and middle income countries, pain management in NICU, retinopathy of prematurity, sepsis basics, to qualify improvement in daily clinical to quality improvement in daily clinical practice. So this is not theory for theory's sake. This is practical knowledge meant to change what happens at bedside tomorrow morning. And I want to take a moment to acknowledge and thank incredible organizing team, and special acknowledgement for Dr. Sajjad. He has been working tirelessly behind the scene to bring us together for this conference. And also my APPNA Peds colleagues, and anytime I ask them something, they always, make me feel proud. So thank you to everyone who have been working tirelessly for this conference. And to our distinguished speakers from Canada, US, UAE, and UK, thank you for sharing not just your expertise, but your time and wisdom. And your presence here sends a powerful message that neonatal care is a global responsibility. And to our moderators, thank you for keeping us on time, on topic, and occasionally keep us muted. And to the participants, especially the residents, fellows, educators, thank you for showing up on weekend. We have been doing a lot of these activities on weekend. This is from our personal time, from our family time, from our kids' time. And before I close, I let you have one simple thought. Every advance in neonatal care that we now consider standard of care once started as an idea shared between colleagues, often in a room, sometimes in a hallway, and now increasingly on a screen like this. So what matters is not the format, what matters is the intention. And if this conference sparks even one collaboration, if it improves care for even one newborn, and if it inspires even one young clinician to think bigger and aim higher, then today has been a success. And with that, it gives me great pleasure to officially inaugurate the first virtual neonatal conference. And with that, I will hand over this virtual podium to Dr. Sajjad Rahman. Thank you, Dr. Sajjad.
Thank you very much, Dr. Sajjad Sultan, for your excellent note. Let's move on to our first session, which will be chaired by Dr. Shahzad Ali Huda, consultant neonatologist from Houston, USA, and co-chaired by Professor Sayyida Shireen, head of neonatology in PIMS, Islamabad. So over to you, Dr. Shahzad and Professor Shireen.
Thank you, everyone. Can someone confirm if you can hear me?
Yeah.
Okay. I just want to show you my face before I turn off my camera. Thank you, everyone, for showing up on time. We'll go ahead and start out with our first session. It will be from our honored guest, Dr. Professor Khalid Haque. He's a retired professor of neonatology from University of Houston and Professor of Emeritus University of Childhood, Lahore. Well known for his research on neonatal sepsis, and he will be talking about the neonatal sepsis today. Over to you, Dr. Haque.
Thank you. Assalamu alaikum. Can I share my slides, please?
Yes. And for participants, if you have any questions, just put your questions in the question and answer session so that we can answer your queries at the end of this presentation. And we'll try to take as many questions as possible. Thank you.
Again, Bismillahirrahmanirrahim, and thank you, Sajjad, and thank you, the organizers, Dr. Sajjad, Dr. Huda, Dr. Shireen, Professor Shireen, for allowing me to participate in this first conference. In the next 25 minutes or so, I would talk about understanding the basics of neonatal sepsis and its management. As I asked Dr. Sajjad who the audience would be, and I believe the audience is mainly from Pakistan, so I have geared my talk accordingly. I have no conflict of interest or anything to declare. But we are going to talk about sepsis, so let us first decide what we mean by sepsis. And some of you are member of WhatsApp group, and recently a question was put up as to the definition of sepsis. And I had to smile because of the discussion which went on about how to define sepsis. The word sepsis comes from the Greek word sepo, which means I rot or to make rotten. And Ibn Sina defined it as putrefaction of tissues. And since then, about 2 centuries, we have been trying to define sepsis. Currently, there are at least 26 definitions of neonatal sepsis being used in medical literature that I know of. But the definition which most academics use is the definition used for adults and neonates. Sepsis is a life-threatening organ dysfunction caused by dysregulated immune response to infection. So there is organ dysfunction and there is dysregulation of the immune response to infection. The problem of using this definition is that in the newborn, not only is there organ dysfunction, but there is also organ immaturity. And very interestingly, though this definition is still used by and currently used by the adults and neonates, Sir William Osler time ago, decided that and gave that opinion about in 1913, that the patient appears to die from the body's response to infection rather than from it. So we have known that it is the body response to infection along with the pathogens which cause mortality. But the definition has eluded us. And current attempts to define neonatal sepsis has given rise to this consortium of experts defining neonatal sepsis called BENOS. And we have been working on trying to define what neonatal sepsis is for the last 18 months. And you might recognize some of the eminent people who are members of this consortium. Why is it so difficult to define neonatal sepsis? The reason is that there are so many variables to take into account to come into one single definition of what we call neonatal sepsis. So as I say, particularly in Urdu, is sepsis ek gorak dhanda hai. It is very, very difficult to define what we mean by sepsis. And everyone in this audience will have his or her own definition. Having said all that, let's talk about the definition and the subject which I have been given to talk about, and that is neonatal sepsis. The burden of sepsis in children, there are about 49 million children who get sepsis every year. 11 million of them die. Of these, nearly 3 million are neonates, and 1 million of them die. The incidence of neonatal sepsis is actually two worlds apart. One, the world is, can't share. One, we are two different worlds. The developed world, where people who are organizing this conference have facilities to do and prevent sepsis, the incidence of sepsis is very, very low. The sepsis occurs mainly in the low and middle-income countries. In fact, 50% of mortality occurs in just 4 countries: China, Pakistan, Nigeria, and India. But isn't it ironic that the most of the research done on neonatal sepsis is done in countries where sepsis is not a big problem? And we only get data from low and middle income countries, but very little robust research coming from them. So I'll try to address that. But my own interest goes back about 50 years. I've been working on neonatal sepsis. And I believe very firmly that neonatal sepsis is where science meets art. Science is understanding its pathophysiology and learning how does the infant fight infection. The art in sepsis is to diagnose neonatal sepsis early and accurately, and how to improve management of sepsis. And this is what we're going to address in the next 20 minutes or so. We all understand the pathophysiology. We all get our innate immunity from our mothers, which is responsible for the immediate reaction which takes place if we get stressed with infection. Or the adaptive immunity, which is a slower response, is that as we get adapted to the environment, more and more immunity develops. So how do we fight infection? Well, the basic thing is that we both, whether it be adult or a newborn, we don't want infection. Infection is bad. So we don't want infection. But if we were to get infection, then how do we fight infection? The adults fight infection. They want to eliminate sepsis, get rid of it completely. Whereas a newborn, and that may come as a surprise to you, the newborn doesn't want to get rid of the sepsis. It just wants to contain it. It just wants to limit it, because the reason is it cannot afford to exert all its energy to eliminate sepsis because it has to grow as well. It has to keep some energy for growth. And I'll be coming back to this point over and over again because it is not very well understood by many neonatologists and certainly by many clinicians working in this field. It is often said that the newborn gets more infection or dies because they cannot fight infection. I think it's a myth that neonates cannot fight infection due to their immature immune system. This is simply not true, as there is a clear evidence that neonates can mount, and I will show you that, a robust pro-inflammatory immune response to infection. We have shown it, others have shown it too. And just to give you an example, let's take an adult, you and I. If we get severe infection, that is colony-forming units of pathogens more than 100 per mil in our blood, we will all die. But if you give about 1,000 colony-forming units in a newborn baby, 25% of them will survive. So that is to break this myth that the babies cannot fight infection. They can actually fight infection better than you and I, but the problem lies is the energy reserve. They do not have the energy reserve to fight infection, grow at the same time. The natural defense systems in adults are fully developed. They are developed in the newborn, but they are slow to activate and slightly immature, but not that they are not there. And this has been shown by Hodgkins et al., and I've adapted this figure from him. When we get up in the morning and we brush our teeth, we get bacteremia from our guts, we get a high pro-inflammatory response, but at the same time, equally anti-inflammatory response, which covers that bacteremia which occurs for a few seconds when we brush our teeth. What happens in the preterm? When the preterm gets infection, it mounts a very good response, but the anti-inflammatory response is rather weak and slower, and it takes a long time to get back into hemostasis. If there is shock, and of course there is a greater response, pro-inflammatory response, it takes even longer for the preterm or the newborn to come back to hemostasis. That is why mortality in the preterm and neonates is higher from sepsis than in an adult. The reason why this takes longer is because it requires a lot of energy, and the baby does not have that much energy reserves. So the next question is, where does the baby get infection from? Here again, I'd like to break some myths. Till recently, it was thought that intrauterine environment was sterile. It certainly is not. It has bacteria and bacterial products that may cause inflammation. We all know chorioamnionitis is a factor, but how many of you know, particularly in low and middle income countries, that maternal gingivitis, maternal dental health is a major cause of intrauterine infection? We ask our obstetricians, do they ever check the maternal dental health or look at their mouth for gingivitis? They don't. We don't. We all agree that prolonged rupture of membranes, maternal UTI, and maternal fever are risk for early onset sepsis. What about late onset sepsis? Late onset sepsis is really dependent on the intestinal microbial dysbiosis. And that is secondary to hypoxia, ischemia, particularly if you don't feed babies. If you don't feed babies, you increase the chances of 16% more infection, particularly late onset sepsis. Early prolonged antibiotic therapy, parenteral nutrition, putting PICC lines and others are responsible for late onset sepsis. So if I was to summarize in one slide, because of time, what is the pathophysiology of neonatal sepsis? You get infection, the microbial products, affect the endotoxins, the exotoxins, activate the toll-like receptors, and a metabolic immune genomic storm starts, which leads to apoptosis, necrosis, autopsy, and that causes chaos at the vascular, epithelial, endothelial, and mitochondrial level, causing tissue damage. It is this chaos which leads to multi-organ failure, death, and that is what we need to stop. We need to stop here, that we don't let the baby go into this chaos, what we call the response to infection. Systemic infection, we sometimes try and isolate it and say it is pneumonia, or it's liver disease, hepatitis, or renal failure, or gastroenteritis. But sepsis overall affects all organs of the body. But the two which I've put in the block are the main reasons in late onset sepsis. There is much more higher incidence of meningitis and higher incidence of cardiovascular shock, which does not usually occur in early onset, but can do, but is much more common and much more frequent in late onset sepsis. So all systems of the body are affected in sepsis. Meningitis and shock are particularly associated with late onset sepsis. So that was enough science, I think. Let us go into the art of neonatal sepsis. Early and accurate diagnosis, recognizing and managing chaos, prevention, and evidence-based specific therapy. There are many difficulties clinical in diagnosing neonatal sepsis. The subtle or absent signs and symptoms. The signs and symptoms are often non-specific, overlapping with other conditions like hypoglycemia, asphyxia. And the babies can deteriorate very, very rapidly. And quite often, it's the junior doctor who makes a subjective judgment that the baby has got sepsis. And then in the morning, when you come around and you look at the history and you say, perhaps baby did not have sepsis. There are many difficulties in clinical diagnosis of sepsis. But this is a wonderful study, long time ago, nearly 21 years ago, by Gerald Fischer from Zurich, who showed that repeated clinical examination by a senior clinician is as good as the biomarker of CRP and PCT. So do not discount the value of clinical examination and experience. It is virtually as good as any biomarker we have. But some clinicians, being clinicians, we want to support our fears with investigations, and so we try and investigate and try and find markers of sepsis. But in fact, when you look at what markers should be, ideally they should be 100% sensitive and at least have an 85% specificity. None of the common markers being used at this moment in time are either, I don't know where these lines have appeared, are either Khalid Kamal Saab is putting these lines on. I apologize, Khalid Kamal Saab. Please do not do that. Do not spoil my slides. None of these tests meet either. If they are sensitive, they are not specific. If they are specific, they are not sensitive. I apologize for this disturbance. I think I saw that Dr. Khalid Kamal has, for some reason, has put these lines in my presentation. I apologize for that. So we often do white blood cell count, and we take less than 5,000 or more than 30,000 as suggestive of infection. But do remember that it takes about 4 to 6 hours for hematological biomarkers to develop. Hence, the initial CBC done may be normal, but you should repeat it between 4 and 6 hours. We often do absolute neutrophil count. If it's less than 1,800, then we say it is sensitive or specific. The sensitivity is about 80-85%, and specificity is 75%. I really am very sorry for these lines which have appeared from Dr. Khalid Kamal. I don't know why. So blood culture is the considered to be gold standard, and reported positivity rate vary from 12% to 90%. But we don't do anaerobic culture, so we don't detect anaerobic infection, which is responsible for about 17.6% of neonatal sepsis. Most of the blood cultures in developed world come back within 36-48 hours, but does not come back for sometimes up to 10 days in low and middle income countries. In low and middle income countries, lots of people rely on CRP. Literature suggests that CRP, from being an excellent marker of sepsis to being a total crap or waste of blood and time. My own view is CRP is not a good test for diagnosis of sepsis, but may be a useful tool to monitor response to treatment. PCT is only slightly better for late onset sepsis, but not early onset sepsis. What about CSF? Less than 20 white cell count is considered normal. Anything above that is abnormal. But quite often, the CSF is blood-stained. There's little value in the diagnosis of meningitis by calculating various formulas. They are not very good markers of meningitis. Marginal cell count plus CSF glucose, less than 50% of blood glucose, you should consider meningitis. CSF protein 180 or above, poor prognosis. Blood culture is negative in 38% of meningitis. LP, I think we should always be done in late onset sepsis, or if there's maternal history of GBS with no prophylaxis. Early onset sepsis, we tend to do LP when the culture is positive. But the point which is very important, which quite often is not taken into account in low and middle income countries, is how soon do you look at your CSF. The earlier you look at it, the better, because the degradation of white cells and the neutrophils is very, very rapid in the CSF. If you analyze the CSF hour and a half to 2 hours after, you will get totally false results. Laboratory tests have moved on from white cell count right down to now onto biosensors. And I just wanted to point out to you that how we are slowly advancing in trying to diagnose sepsis early and accurately, because we want to know what are not only what the pathogens are, but what the pathogens are doing and how are they doing and what are they doing. So there are new biomarkers. There are risk calculators, high-resolution ultrasound, which can detect meningitis with 94% sensitivity and specificity. There are multi-tier analytic systems. The microbiome tracking, looking for a protobacteria surge, which occurs a few before clinical sepsis occurs in the stools. Transcutaneous monitoring of acute phase reactions. InSlip measuring white blood cell bioprofile. But I think the most exciting work is the SeptiCheck, which is being tested in animals at the moment, but will be soon tested in humans, is a transcutaneous monitor that provides continuous reading of heart rate, tissue oxygenation, circulating bacterial metabolic products, has a sensitivity of 93% and a specificity of 94%. But that's later, that will come. It will take a few years. But what do you do when you suspect sepsis? Well, if you examine and the baby looks healthy and normal with no abnormal symptoms, wait, don't start treating, come back and examine again. If the baby is sick appearing and sick, then there is no time to waste. So these are two easy answers. What about when you're not quite sure if the baby is sick or not quite sick? Then I think repeated examination and blood tests are useful. And I think one of the most important tests is to do a neutrophil to lymphocyte ratio. If it is more than 1.5, you get a sensitivity of 80 and a specificity of 94%. This is not applicable to early onset sepsis, but you will get it very good diagnosis of late onset sepsis. So now we come to the decision point, the antibiotic therapy. Should I treat? Should I not treat? What should I treat with? And how long should I treat with? Currently in the United States, 20 infants are treated for late onset sepsis for every one infant with late onset sepsis. And 75% of neonates are treated for suspected early onset sepsis. In Pakistan, the ratio is 1 to 30 to 80. Remember, antibiotic cause microbial dysregulation, reducing the diversity in the gut, which causes later on may be responsible for neurocognitive disorders. So antibiotic therapy is not that benign, and we need to be very careful. It is, of course, the most commonly used in neonatal medicine, but is also the most commonly misused in neonatal medicine. In USA, as I said, 6 to 20 babies get antibiotic for every one which is infected. In UK, it is 10 to 20. In Pakistan, in our study in 2019, we found it was between 30 and 88. So what are the principles of sepsis management? Specific early recognition, early source control, early identification of hemodynamic phenotype. I don't have the time to talk about that. Targeted therapy, again, I don't have the time for. I will just talk about support for organ dysfunction. And you see, of course, remove any long lines which may be causing infection. I will just mention about optimized nutrition and antimicrobial stewardship. There are many ways of protocols which we follow. This is our protocol. When we have risk factors, we suspect sepsis, an ill-looking baby, we do initial tests, blood count, and we repeat it after 6 to 12 hours. We start penicillin and gentamicin. Our management, if the blood culture is positive, we continue antibiotics and, of course, do lumbar puncture. If the blood culture is negative and the infant is well, lab data is reassuring, we stop antibiotic at 36 hours. If the blood culture is negative and infant is still unwell, we repeat the lab and the lab data is non-reassuring, we continue antibiotic, do lumbar puncture, and repeat the tests. The reason why we do this is because if in true sepsis, if you delay giving antibiotics, for every hour delay in administration of antibiotic, mortality increases by 40%. So we haven't got time to waste. We need to make a decision as soon as possible. And as Dr. Savdar said, we often make life-saving decisions. The question then comes for how long should we give antibiotics? Every time I ask the audience what should be the duration of antibiotic therapy, universally I get the answer, we give a course of antibiotics. The question is, what is a course? I do not know. Our own policy is that empirical antibiotics, we have a very hard stop order. We stop at 36 hours or 48 hours as soon as we get our blood cultures, if it is negative or positive. If it's positive, we give 5 to 7 days. If it's gram-negative, we still give 5 to 7 days. If it's meningitis, we would give 14 to 21 days. If there is negative but the baby is unwell, we would repeat cultures and decide again. The reason is that early antibiotic exposure in preterm infants is associated with risk of neck and late onset sepsis. But this is heavily debated. We know from studies that if you give antibiotics up to 5 days, the harm is very little. And in fact, some people have suggested more recently, the pendulum is swinging the other way, that giving antibiotic for 72 hours or so may actually be beneficial. But certainly giving antibiotics for 10 days or longer, you really are risking great harm to the babies. So the longer the antibiotic therapy, the greater the microbial dysbiosis and the likelihood of short-term, medium-term, and long-term complications. I don't have time to go in the benefits of giving antibiotics or the harm of antibiotics, but I've got this literature. You can read it up yourself. Now, what antibiotic to give? Well, that depends on what organisms you have. And we've just recently finished analyzing a very large data of 7,000 blood cultures from Pakistan, which of 26% of which were positive, 74% were gram-negative infection. And you can see the most common infection are Klebsiella, Acinetobacter, Pseudomonas, and of course of gram-positive Staph aureus and Coagulase negative. And there is regional variability in Pakistan. So in federal area, Klebsiella is common, so is in KP, but Klebsiella is not that the first organism. E. coli is first in Punjab and in Sindh. And similarly, there is a lot of other organisms vary according to the region. And interestingly, what we have found is the common antibiotic which people are using in Pakistan have a very high incidence of resistance. And that is why our mortality is high, because we are not using the correct antibiotics, depending on based on our antibiogram which we have. So my suggestion is that you should choose your antibiotic according to your antibiogram and resources. With reported incidence of 35% meningitis associated with late onset sepsis in Pakistan, I believe starting empirical antibiotics in late onset sepsis should be with meningitic dose till the CSF results are available. You must establish antibiotic stewardship. Consider the benefits and harm from antibiotics, choice and duration of antibiotics, as I have alluded to earlier. The adjuvant therapies, probiotics, the Americans are not allowed to use probiotics. Europeans use it in 90% of cases. Many other countries in Southeast Asia use probiotics, and the meta-analysis shows that they are certainly very beneficial in management of neonatal sepsis. But more importantly, the most important and cheap benefit adjuvant therapy is breast milk, and breast milk. And interestingly, this is not true for pasteurized human donor milk. Pasteurized human donor milk, because it loses lots of its goodies. It does not prevent infection as much as mother's exclusive breast milk or colostrum. My last two slides will tell you that I have focused on nutrition and the energy needs which the baby needs to fight infection. And here is an example. A world champion cyclist, when he's racing, requires 100 kilocalories per kilogram per hour while racing. Our little preterm baby, just to survive, requires 120 to 130 kilocalories per kilo per day just to keep alive. But the difference between the cyclist and our neonate is the amount of stores, which I have shown you in green blocks. And when the cyclist is running a cyclist race, he uses his energy, but at the end of his race, his reserves are left. While in our preterm baby, when they fight infection, there is nothing left in energy, and that's why they get organ failure much more frequently than the adult. So please, neonates require more kilocalories per kilogram per day due to stress of sepsis, not less. So please do not stop feeding. Give trophic feeds, TPN if you can, or start early enteral feeds as soon as possible. Develop nutritional stewardship is required because demand is high and stores are limited in the preterm. We always focus on antibiotics, we focus on resistance, but we forget nutrition of the baby. We try and prevent infection by wearing gowns and chappals. That doesn't prevent infection. Surrounding the baby with 20 people on ward rounds doesn't prevent infection. Overcrowding, I know, which is sometimes necessary, does not prevent infection. This is a view from a neonatal unit which I was asked to visit. We had to leave our shoes outside and wear these chappals to go in. But as Avicenna told us, wash your hands before and after you see the sick baby. Use alcohol gel, try breastfeeding, prevent prematurity and prolonged rupture of membrane, give GBS prophylaxis, and you'll be able to prevent infection, because an ounce of prevention is worth a pound of cure. And germs-free hands, please, in neonatal units. Do antimicrobial stewardship. This will save you drugs. This will save you costs. This will save you lives. I would like to end with just two slides. Having given you the basics, We still have to fight infection. There are still some problems which we haven't got the answers for. Why do some babies survive and others die with similar infection? We don't know. Can we predict severity of sepsis to individualize therapy, precision medicine, because we know clearly one size does not fit all? What real benefits are in breast milk so that we can harvest them and use them in babies who cannot be breastfed? Can artificial intelligence be more informative marker and therapeutic tool? Can we optimize pharmacodynamics? We at the moment use antibiotic per kilo per gram, but we don't take gestation into account when we are giving antibiotic, because we know their pharmacokinetics and pharmacodynamics are different, and we need to develop informative bedside dashboards for multi-tier analysis. So my last slide, ladies and gentlemen, is to take to work. Usually people end by saying take home messages. I think home is for resting. The message to take to work, as no matter how you define neonatal sepsis, repeated clinical examination for early recognition and treatment is critical. Timely and targeted empiric antibiotic therapy. Empiric therapy should stop 36-48 hours unless culture is positive. Choice of antibiotic depends on your local antibiogram. Duration of therapy, this is our recommendation, but it's not universal. Current biomarkers are not very helpful, but advances are in pipeline. Intrapartum prophylaxis, good hygiene, antibiotic stewardship are the hallmarks of neonatal care. Mother's breast milk is both protective and therapeutic and should be initiated as early as possible. And I end up with this verse from Bulleh Shah, and I thank you for your attention and happy to answer any questions. All what I have said is available in our textbook of pediatrics, which was published 2 years ago. Thank you for your attention again.
Thank you, Dr. Haque. It was a wonderful presentation. Due to time limitation, we'll take the questions after the next session. It will be Dr. Khalid Al-Turkawi from College of Medicine, University of Sharjah. And after Dr. Khalid's presentation, we'll take all the questions. Kindly keep putting your questions in the chat box so that we can answer accordingly. Dr. Khalid, can you hear me?
Yes, sir. Assalamu alaikum.
Wa alaikum salam. Thank you, sir.
Thank you very much. Can I be the co-host?
Yes, let me make you co-host.
I hope you'll be able to see my slides right now.
Yes, we can see it.
Sure. Well, assalamu alaikum once again. And after this beautiful presentation by Professor Haque, I hope that you will be able to enjoy my a little bit depressing talk regarding therapeutic hypothermia in the low and middle income countries. So I'll try to start with a little or brief talk about what's HIE all about. Is therapeutic hypothermia suitable for the LMICs? And I'll try to challenge the concept that therapeutic hypothermia is not fit to be used in LMIC settings. And hopefully within the time frame you allow me, I'll try to cover most of that. At the beginning, let me distinguish between two things which are used interchangeably and sometimes creating a little bit of confusion. Number one is the so-called neonatal encephalopathy, which is a clinical syndrome of neurologic dysfunction in the first week of life, while the hypoxic ischemic encephalopathy is a subtype of a neonatal encephalopathy. The neonatal encephalopathy itself is a kind of clinical syndrome with diverse causes and many risk factors. including inborn error metabolism, toxicities, maternal malnutrition, and among others. While when it comes to hypoxic ischemic encephalopathy, we are referring to something related to an insult. Hypoxic ischemic insult happened around the time of birth, probably a little bit earlier than parturition itself, or throughout the time of the delivery. Let's look at this paragraph or kind of schematic representation of HIV. The insult, which we are referring to as a triggering point, induces reduction or critical reduction in glucose and oxygen delivery to the tissues, particularly the vulnerable areas in the brain, which leads to a critical reduction in ATP production, and this set the brain itself or the vulnerable area for early primary energy failure and cell death. This happens usually within the first few days after the insult itself, and it may last for a few hours, leading after a latent period to a secondary phase characterized by mitochondrial failure. In this phase, along with the primary phase, we get more of oxidative stress, inflammation, and excitotoxicity. Now, this is the classical view of the two-phase kind of hypoxic ischemic encephalopathy. However, the evidence nowadays points towards having a third phase, which comes usually after the third day of the insult, and which continues probably for several weeks or months, characterized by epigenetic changes, impaired repair, remodeling, and late cell death. Now, how to halt this or how to avert the problem of the hypoxic ischemic encephalopathy? Before the 1990s, probably there was really no much things to do about it. However, in the 1990s, few experiments started. Animal studies started early on in 1950s, but non-randomized trials started in 1990s, looking for the possibility of trying to halt the problems by applying coolness or cold environment to the brain. This controlled cooling thought of that it will decrease the metabolic demands and allow the cell death to be forestalled and the cells to recover faster. So in the 1990s, some experiments started to show a little bit of benefits, which encouraged for later on in the early 2000s to have randomized controlled trials in children with severe hypoxic ischemic encephalopathy. Now, these controlled cooling, which lasts for about 72 hours and was applied only for children who are, or for infants who were born at 36 weeks of gestation and beyond. These infants have to be really having a consistent history of perinatal depression, biomarkers of perinatal acidosis, and signs of encephalopathy. The children were subjected to cooling either the head or the whole body for that period of time, and to have the core temperature of the body to reach somewhere between 33 and 34 degrees centigrade. Indeed, most of these experiments resulted in an improvement. 3 landmark studies, indeed, show very promising results. And the rate of mortality combined with neuronal or neurodevelopmental impairments decreased by roughly 20 to 30% in most of these studies. However, all these studies came with one good conclusion, that the therapeutic hypothermia is safe under intensive monitoring and is effective to decrease the death and NDIs by roughly 25 to 30%. At the moment, if you look at the latest Vaughan network usage paragraph, it shows that the rate of use increased by roughly 60% between 2012 and 2021, which means that this kind of modality of therapy has established itself as an effective and safe therapy in the high-income countries. Anyhow, there are so many lingering questions related to the best way to approach this therapy. Should we cool for longer than 72 hours or even shorter? Should we cool at a lower temperature? Should we cool beyond the therapeutic window, which we refer to as the first 6 hours after the insult? Should we cool for cases that have mild encephalopathy, not severe? Should we cool preterm infants? All these questions really need to be answered before we can move forward. Some other questions related to adjuvant therapy and kind of monitoring techniques and prognostication techniques. Finally, and one of the most important questions is, should we cool infants in hypoxic ischemic encephalopathy with a hypoxic ischemic encephalopathy in LMIC settings? Now, why we are asking this question? Because most of the studies which done in LMIC settings showed that really therapeutic hypothermia wasn't as effective as it was shown in landmark studies in the West and North America. Why is that? Really, it's not very clear, but however, the question itself deserves really a good answer. LMICs are very different from high-income countries, one way or another. The difference is probably in a high burden of the HIE in these countries. About 95% of infants with HIE are born in LMICs countries. Just imagine 5% of the children who are treated with therapeutic hypothermia are in wealthy countries, you can say. And all the studies which are showing efficacy and safety came from that region of the world. Nonetheless, 95% of the infants who are born in LMICs countries are really just having a free ride, you can say, without much studies done on this population. All the studies done were very small and showing no much efficacy. Now, we know for sure that LMICs countries have limited resources in terms of therapeutic, imaging, and monitoring. And the healthcare delivery system has much problems in terms of governance and policies. And the patient mix also are not necessarily the same of patient mix which we see in the West. Higher rates of comorbidities, especially of sepsis and other malnutrition problems. Now, the challenge here right now, I'm just trying to portray it as whether LMIC designation itself really makes sense in this regard. Let's remember that LMIC refers to low and middle income countries. And this classification has been proposed by the World Bank in order to track the growth and the financial stability of the countries. The so-called GNI per capita is what matters here. They divide the countries between low middle, upper middle, and high income countries. Low income countries are those who have about $1,045 per year as an income per person. And while high income countries are those who are more than $13,000 per year per person. The grouping itself is very dynamic. So who is in LMIC country designation as of now, next year might be not, or the other way around, based on many financial factors. It has nothing to do with the healthcare system itself. It is just a designation by financial institutes. The question here rises, how strong is the association between the outcomes and the GNI of any given country? It's really not very clear. More importantly, I would like you to remember that the LMICs countries, as of the year 2023, were about 129 countries. They represent about 73% of the world population. So any studies really directed towards this population is worth doing. But the catch here that LMIC designation is really unfair and it's very limited. Why? Because it groups so many countries together, while in reality they are very much different. Take this example which I put for you. China and Burundi, two countries are in the same category of LMIC. China has an incidence rate of LMIC of HIE is about 13.9 per 100,000 population, while Burundi is about 3 times of that. So then the incidence is higher. The mortality, on the other hand, is also about 20 folds higher in Burundi than what it is in China. Now, if you look at the GNI per capita, China has about 13,730 in the year 2025, while Burundi has only $190 per person per year. It is about 70 folds difference. Now, it is really impossible to be classifying these two countries together and to say hypoxic ischemic encephalopathy can be treated equally by therapeutic hypothermia in these two countries or cannot. We need really a different system to approach this issue. And I'm proposing here that we need readiness-based classification system. It's not the time really to elaborate a lot about it, but readiness classification system would allow us to speak about that this unique setting, whether it is within a country or between countries, is ready to take this kind of modality or not. That's another story, but let me focus today on something else. How schooling is practiced nowadays in the LMICs as it is. Mostly it's passive and low-cost cooling. The advanced and servo-controlled setting of cooling is probably beyond the reach of so many countries. Passive cooling means that to switch the heater off, use fans, ice packs, or gel packs. And this is very common, and it has been studied and shows a little bit of promise in some situation. Phase change material beds, as you see in this photo, is probably what is more promising than others. There's another way of cooling. It's called evaporative cooling devices. I'll show you a picture later on. And more importantly, a prototype of neonatal flow kind of device is invented and being right now tested in somewhere in Brazil. The pros of this kind of cooling is, of course, it's low cost and easily accessible anywhere, but the cons are really related to the poor temperature control, which keeps most of the babies sometimes out of the range of effective therapeutic hypothermia. Now, the PCM cooling mattress is a really simple concept. It is made of several layers. The middle layer here in this graph is the layer which producing the coolness, and the baby is put on top of the conduction mattress. If the core temperature of the baby is reduced to lower than acceptable limits, another layer will be put between the baby and the mattress. If the temperature rises above the limit, they will just remove the conduction layer and allow the baby to resting directly on the cooling surface. However, this device, along with the other devices, are having the same trouble. In the left side of this slide, you see the kind of so-called evaporative cooling device. It's simply made of two potteries, one inside the other, separated by a layer of sand and ammonia. And this sand is a little bit wet, so it allows for evaporation. And whatever in the middle is going to be cooled enough to a degree beyond the range which we are looking for. Indeed, in their study, they reported that the temperature can be as low as 17 centigrades in a room temperature when it is 25 and above, after 2 hours of using this device. So essentially, this device can cool the baby to a temperature lower than what we want. However, there is a way to manipulate the temperature and the coolness while attaching the baby to a rectal probe and decreasing the temperature of the device itself. More importantly, there is another team in Brazil trying to kind of work on this prototype, which is called Neonatal Flow. They claim that it's, as of now, it's showing promise because it works relatively in the same way like laminar flow devices, which we are using as a servo control devices in the advanced countries. However, the studies as of now are not showing any figures to be able to support their claims. The price of the device on the left is roughly, according to the authors of that study, is about $30, $31.5. The one on the right is not announced yet. Nonetheless, all of that really is not important as compared to what the study which changed the game is going to tell us. Everybody is aware probably about Helix trial, which was published in 2021. All the studies, the smaller studies published from LMICs setting, were showing no improvement whatsoever in terms of using therapeutic hypothermia, but none of them really showed that the devices used at that time causing harm. This study came with a conclusion that LMIC settings are not really suitable to apply therapeutic hypothermia because it may lead to harm when it is applied to babies according to the same protocols used in the West. The study itself came under a lot of scrutiny, a lot of criticism. Nonetheless, if you read it carefully, the study has followed the same kind of protocols which are followed in TOBI trial and some other respected studies done earlier. So it seems to me at least that the study is valid in terms of how it is applied. Nonetheless, there might be some other reasons behind this study showing that the therapeutic hypothermia is not effective. Indeed, it might be harmful. We'll discuss it later, but anyhow, just this study triggered a lot of later on similar, you can say similar smaller studies. None of them reached the same level of conclusion. For instance, this systematic review looked at 61 trials, including about 5,000 children or 5,000 infants for studies done between 2010 and 2023, I think. And all of these studies were relatively small, with low and moderate certainty of evidence, and therapeutic hypothermia effects on mortality and NDI differed, according to this study here, by center and by the cooling device used. At the same time, or almost the same time, another team looked into systematic reviews and meta-analysis, and look into about 18 studies, all of them RCTs, and they found that the certainty of evidence is mainly in the low to moderate range. However, no definitive advantage on mortality, and when it comes to NDIs, there was a little bit of reduced risk. Another systematic review done by Prakash and his colleagues, they looked into about 11 RCTs, and they tried to look into in their opinion, the best RCTs which can give the least bias risk. And they found almost the same thing, that there's no significant difference in terms of mortality. There is a little bit lower difference in terms of the NDIs at 6 months of age. Nonetheless, the last meta-analysis looked into 11 studies with high quality, 3 good and 8 of them excellent evidence level, and compared the early and late outcomes between the groups, between the group who received the therapeutic hypothermia and the one who is receiving the regular care. And they found that between the group differences, only the late outcomes, which means 6 months and later, were different and showing major kind of what they call effect size. While at early, the effect size was very minimal. It's about 0.16. This is a D-con factor. Within the therapeutic hypothermia, the differences between the early and late outcomes were remarkable. Both of them showed increased effect size. Roughly speaking, this means that therapeutic hypothermia applied appropriately according to the protocol will improve the late outcomes effectively and may not improve the early outcomes that effectively. Now, let me sum it up, if you don't mind. Most of the studies done in LMICs are really small trials. Overall, it's a low to moderate certainty, and the outcomes varied considerably across the centers and the type of device used. The lack of benefits, in my understanding, might be attributed to several things, some of them related to the infants themselves, who have a higher burden of comorbidities, which probably diluted the treatment effects. And some of them might be related to the investigators and the lack of experience and limited ability to assess or to apply the therapeutic hypothermia effectively. And finally, and probably more important, is the context and the system where things are conducted, the facility diagnostic, the supply chain, and the governance effectiveness. All of these things might be really contributing to having different outcomes in LMICs than what it is in high-income countries. Now, as long as we are speaking in Pakistan, let me just shift the gear towards a little bit of Pakistani context here. And the burden of HIE in Pakistan between 1990 and 2023 showed really a mixed picture. And if you look with me on the incidence of HIE on the left part of the graph, and here we go, the dotted red line indicate the drop of the incidence globally, while the orange-colored part or graph is the decline of the HIE incidence in Pakistan, which is far better than what it is globally. However, when you look at the regions within the country, you see an interesting the kind of disparity. For instance, this Islamabad area and the central part of the country probably witnessed a little bit of an increase of incidence between 1990 and 2023, along with the Sindh region. This increase in the incidence probably related to having more high-risk deliveries happening in these regions of the country as compared to other places. For instance, Baluchistan, which is not so probably well served, has witnessed a decreased incidence of the HIE as compared to Islamabad, which is a little bit counterintuitive. But however, I think what is really going on at this moment is that more of these high-risk deliveries happening in the central area in Islamabad, the capital area. When it comes to mortality and disability, the picture is also interesting. Pakistan in general has witnessed about 18% decrease in mortality rate, while globally there was about 37% decrease in mortality rates. Within the country, the Cape region and probably Baluchistan have increased mortality, which means that these regions of the country, which witnessed decrease of the incidence, also at the same time witnessed an increase of mortality in these babies born in these regions, which alarms us that these regions has to be served in a better fashion. Nonetheless, the Islamabad area, as you see, the decline is remarkable. It's about 30% or 40%, decline from the baseline of 1990s. The same thing for disability. So there is disparity. How to address that? That's up to the people on the ground. However, is therapeutic hypothermia really a good option to be addressed in Pakistani context? Well, looking at the vital statistics of Pakistani population and total birth, in the 2021, there was about 6.7 million births in Pakistan. And I think by 2025, it's a little bit higher. Neonatal mortality rate is somewhere around 38.5 per thousand. And neonatal death collectively amount to about 258,000 babies. The HIE incidence, according to the GBD study, and the last version of it is 2023, showed that the incidence is about 14.9 per 100,000 population, which means that in Pakistani regions, there is at least about 37,000 cases of HIE each year. Now, assuming that therapeutic hypothermia is applied effectively and appropriately, the reduction of this load will be somewhere around 25 to 30%, which means that we'll be able annually to save at least 8 to 10,000 lives. And we'll be able to reduce also the NDIs by roughly 25 to 30%, which will entail a reduction of the cost of taking care of these infants throughout their ages. Just to put you in the overall picture of how much it may cost lifetime-wise to take care of a baby or an infant or a child with cerebral palsy. The CDC announced in 2003 that the care of one infant with cerebral palsy, a lifetime care, which amounts to about $900,000. Now, adjusting for inflation, this number will be in 2025 roughly around $1.6 million. So, if you manage to take out of this load about 10,000 of babies off this load, you are really making a major impact of how much you are relieving the financial constraints on the healthcare system in Pakistan. So the current challenges in Pakistan, in any other LMIC country, would be really lack of devices and low diagnostic and monitoring capacity, the limited trained health workers, and probably the healthcare access and quality in general. What to do about it? What the solutions which we are really trying to imply here? Should we adopt or avoid therapeutic hypothermia? In my best understanding, we have to build the capacity to apply therapeutic hypothermia in a standard fashion and create neuroprotection centers throughout the country. But while we are doing that, we should focus on optimizing the prenatal and neonatal care. There are several things can be done which are cheap and possibly within reach. Improve the training for resuscitation. Consider using the DCC and cord intact resuscitation. Target the mixed pathologies, particularly fetal growth restriction and sepsis issues. And explore so-called make obstetrical care secure modeled initiatives. We'll speak about it later if time allows. The second issue is to try to contextualize or context-tailored protocols and standard creation. Use therapeutic hypothermia selectively for low-risk neonates, and those can be identified by better biomarker-based selection. And you may use pre-transport passive cooling as temporizing measure. And lastly, and more importantly probably, is the regionalization of programs of therapeutic hypothermia across the country. Now, I gave myself the liberty to push the envelope a little bit here and think about if I were to create a system which allows for regionalized network from scratch. Now, I'm not ignoring that there are so many good centers throughout the country which are handling the therapeutic hypothermia, but nonetheless, to augment these centers, we probably need to think about that there should be a center within 6 hours reach from every location in Pakistan. If we have no such facility, no such center which can handle the therapeutic hypothermia, it has to be created. Now, looking at the Pakistani region, which is about 800,000 square kilometers, we roughly need about 40 to 50 centers scattered throughout the country to allow for at least someone to get care within 6 hours of the therapeutic, with hypoxic ischemic encephalopathy insult. And as a start, there might be somewhere around 15 centers located strategically throughout the country, which allows for 85% to 90% of the population of eligible infants to be cared for. And another 15 centers might be considered so-called stabilization centers, which they can offer very primitive therapeutic hypothermia care to be transferred later on to the major centers. If this kind of what they call it regionalized therapeutic hypothermia network is established, we can look for about 90% reduction of the problem within the next 5 years, assuming that there will be a functional neonatal transport system. What about the research? Certainly there should be some research located or localized research. First of all, the context-specific RCTs are really very important, particularly in the Pakistani context. Then we should consider experimenting with the safer and low-cost devices like the ones I just alluded to. Think about long-term follow-up and establishing registries and assessing the outcomes pertinent to the local population. And finally, add to the world knowledge in terms of what justifies utilizing a given therapy, or particularly in infants of LMICs countries. And let me leave you with this take-home message. Therapeutic hypothermia is a standard HIE therapy in high-income settings, for sure. It may be harmful in LMIC, likely due to the system failure, not because the procedure itself is harmful. Current evidence suggests that it shouldn't be used as a routine part of the care, but nonetheless, I am not very much certain about this. Basic prenatal and neonatal care should be prioritized. Regional networks are essential for timely referral, fair distribution of resources, and equitable access. And locally adapted standards and protocol are very much in need. And later on, nationwide context-based research is certainly crucial. Should we really do that? Certainly yes, because every soul you can save is worth saving. And whoever saves a life, it will be as if they saved all humanity. Sadaqallah al-Azim. Thank you very much for listening. I'm ready for your questions.
Thank you, sir. I'll hand over to Dr. Gul to take over.
Thank you so much, Dr. Khalid, for such an excellent talk. Basically, I think we are short of time as well. So maybe we can take few questions. The first question is from Dr. Haque. Dr. Haque, are you there?
Yes, I am.
Yeah. The first question is, what is the role of pentaglobin as an adjuvant in the neonatal sepsis? And second is, when to use antifungals? Because you have given role of antibiotics, but we do use antifungals as well. So what is the indication of antifungal?
Two very good questions. The first one I'll answer first, and I must declare that I am biased because I pioneered the work on pentaglobin, so my answer will be biased, and I declare that openly to all the audience. The evidence there is very clear that it is beneficial in gram-negative sepsis, and now, more recently, within 2025, 3 to 5 papers in adult medicine have been published in adult intensive care unit with gram-negative sepsis, where pentaglobin has been found to be beneficial. There have been no further neonatal studies. So with neonatal studies, the evidence is old, our own evidence, and it is biased. My answer is biased. I think it should be used early in gram-negative infection, but that is the evidence. As far as antifungals are concerned, antifungal prophylaxis are only recommended in extremely preterm in intensive care baby units, or if there is evidence of fungal infection. But routinely, we only use it in extremely preterm infants who are undergoing intensive neonatal care, like intensive respiratory care or post-surgery.
Okay, thank you, Dr. Khalid. There's one more question regarding your talk, and that is that whenever there is coagulopathy in the sepsis, then what is the role of FFPs and other modalities for the treatment of coagulopathies or bleeding tendencies in the sepsis?
Yeah, I think again a very good question. Thank you for that. As I said in the very definition of sepsis, there is the not only organ dysfunction but also the immune dysfunction. Now, what happens in infection is that pathogens release their toxins, whichever toxin they may be, endotoxin or exotoxin or peptoglycans or activating TLR. They impact on both vascular endothelium and epithelium and therefore increase the tendency for coagulation. However, there is little evidence to suggest that FFP or transfusion routinely is of any benefit. Yes, if there are coagulation disorders which you can detect, and that sometimes may warrant therapy with FFP or blood, but usually routinely it should not be given.
Okay, one more question from my side is that whenever we are giving in septic shock, the babies we are using inotropes like in epi as well. And then can we still continue with the feed, with the trophic feed or with the normal feed? Because sometimes when people they're very hesitant, even my residents and fellows, and it is very difficult to make them start a feed in a sick child. So this is what I wanted to make clear for myself as well.
Right. Fascinating question. In fact, very interestingly, in January at Indus Hospital, I'll be giving a talk on enteral feeding. And for that, I was looking up at the literature to prepare that talk. And there is now increasing evidence that even when you're using inotropes or radioactive substances, you should be giving trophic feedings because it improves the mesenteric blood flow. So that is important that you should continue with trophic feeding, at least, if not more.
Thank you so much. And thank you so much, Dr. Khalid. And
Dr. Junaid has a question.
Yes, Dr. Junaid, please.
Thank you, Dr. Khalid. Thank you, the other speaker. Sir, I have one or two questions and comment. First question, you said that we are not adjusting the antibiotic according to the prematurity.
Hold on. I did not say that. What I said was the data which we have analyzed from Pakistan, the antibiotic they are using empirically is not conducive to their antibiogram. That is what I said.
No, there is another slide where we said that we are not putting the gestational age into the consideration. On the dosage, or maybe this is something other slide.
Correct. That I did say that. Yes. So now, if you look at any antibiotic or any drug for that matter, how is it metabolized? Now, it is metabolized by various different organs. It is either metabolized by the liver or excreted by the kidney. Now, do you think the liver function and the kidney function of a 24-weeker is the same as a 37-weeker? It is not.
No, it's not. Yeah.
So we do not take that into account, and the pharmacokinetics and the pharmacodynamics are different of a 24-weeker and a 37-weeker, and that we should be taking into account.
Mm-hmm. Okay. And then, of course, for the feeding, we always feed whether the baby is sick or not sick, but anyway, we give the feed with the mother's milk. The antifungal you are talking about is totally different prospects. What do you think about that? Because prophylaxis for antifungal...
It depends entirely on the incidence of your fungal infection. If you have got 10 to 15% or more, then you should be using antifungal prophylaxis, otherwise not.
Yeah, that's my whole point. Okay, thank you, sir.
Just want to add a few points here. As Dr. Khalid mentioned about the pentaglobin and the plasma, just keep in mind these are blood products, so only judiciously use only if you are suspecting strongly. Second thing about the antifungal, as he mentioned, it varies from unit to unit. If your unit has a higher incidence of the fungal infection, then you may end up using the prophylactic one. But if your unit does not have the high incidence, it is better to avoid those medications, because every medication, they have the side effects as well. These are not benign medication. If you're using amphotericin B or fluconazole, whatever you're using, they are not benign, and they have different pathway of the metabolization as well. So it causes more harm than the benefit. And as he mentioned, like the feeding thing, you should continue with the trophic feed, because it continues to promote more and more immunities as well. I had one more thing about the question about that's a personal question related to the Pakistan's turnover of the turnaround time of the blood cultures. When we are selecting the antibiotics, I'm not sure how much we follow the antibiogram of the particular unit. We continue the antibiotic broad spectrum, because I've seen babies to be on colistin, meropenem, ciprofloxacin, which is kind of frustrating for me being sitting here. To whenever I talk to any of the colleagues there, they put those babies on such a broad antibiotics, and they are just waiting for the blood cultures to come back. I'm not sure how quickly or how difficult it is to get at least the initial gram staining in the Pakistan, because whenever you call them, they're like, you have to wait for 5 days for the blood cultures to get reported. Do you have any suggestion for that, Dr. Khalid?
Well, we did publish a study in 2019 where we looked at a number of units in Pakistan, and the turnaround time of blood culture varied from 3 days to 10 days. So in fact, blood culture is very difficult to get, and many units did not have the facility to do, or the blood culture bottles. And if you ever visit some of the units, and some of the, in bigger cities as well, I have seen blood culture being sent in bottles of empty bottles of penicillin, which have been emptied, and then the blood culture has been sent. So that is the question about gram staining. Remember that it requires somebody to look at strain the slide and look at it. And the resources available in laboratories in Pakistan, in many places, are rudimentary. And so you do not get that gram staining available to you. I think, as I pointed out in my slide, that the incidence of sepsis is high in low and middle income countries, but the research is done in the high income countries. And people try and put that together. It's very difficult. Those are two very difficult, different worlds. And I sometimes wonder that a lot of our colleagues who have trained in Pakistan but now work abroad seem to forget the resource limitations of Pakistan. These people who are working in Pakistan are doing a heroic job in the resource limited facilities which they have. And I think we really need to help them as much as possible, but we also need to congratulate them in what they have been doing in trying to reduce the neonatal mortality and improve neonatal care.
I add on one thing. I'm working in PIMS. And it's basically Trashikir and the major public hospital of federal area. So blood cultures, even in our laboratory, they come after 5 to 7 days. And if we sometimes we just ask, just tell us if there is any growth or not about the exact organism, but the growth itself. So, and the second, I just wanted to answer Dr. Shahzad, that we don't wait for the cultures, we don't switch antibiotics so quickly from first line to second line to meropenem to colistin to tetracycline. It's not like this. Basically, is that we always start, we have an antibiogram of our own department and we follow it. And basically, whenever there is clinically, because against Dr. Haque said that it is an art to treat the sepsis, because sometimes you don't have much time, you don't have a bigger window, and sometimes you have to take a step and change the antibiotic even before the blood cultures. And in that time we also see that what are the common organisms we are growing in our cultures, and what is the antibiotic which is sensitive to most of the organisms. So we switch at that time, not regularly, but sometimes we do switch antibiotic without the culture, depending upon the clinical status of the baby as well. And secondly, in some in the peripheries, we don't have even the facility to do the blood CP. So what to talk about the blood culture and waiting for it in Haripur? We are working with WHO and UNICEF to upgrade our DHQ's hospital and their nurseries. So when I go there, I see that they are even working with meager resources than us. So it is really a heroic measure to decrease this morbidity and mortality.
No doubt, no doubt. Yeah, you guys are doing a tremendous job there. I visit every year to my parent institution, which is NICH Karachi, and I see all kind of work you guys are doing on the ground. A tremendous amount of work it needs there, and effort needs to change the culture as well. We'll move forward to second talk's question. If anyone has any question about it, kindly put it in the chat box. And for Dr. Al-Tarkawi, regarding the therapeutic hypothermia on the lower middle income countries, I think for the Helix trial, I would say more harm was seen, might be because they were might be a little bit late in the process when the therapeutic hypothermia was initiated. There were like tons of comorbidities were reported in that Helix trial as well. And correct me if I'm wrong, because sometimes what happens that in countries like Pakistan, where we have like interracial marriages where you don't know about the genetic factors on those kids as well. So might be tons of genetic issues would be involved, not just in the Pakistan, even in the Indias as well. So might be those cofactors were involved. But again, the time factor is very important, like the way you have mentioned about the first 6 hours. But there are certain studies coming out right now where they are talking about the secondary phase of the injury, where you can do the therapeutic hypothermia after 6 hours of life as well. But depending on what were your comorbidities were, might be they had like early on to sepsis, and then you are putting them on the hypothermia. That may cause more harm than the benefit, because your coagulation factors would be off, and the therapeutic hypothermia already have like one of those side effects where you're not having like proper coagulations as well. Anyone has any question on the therapeutic hypothermia?
Yeah.
Yes, sir. Yes, sir. Go ahead.
Yeah, Shahzad. Thank you, Khalid, and thank you, Shahzad. There's the two things I have to, because I'm also visiting Pakistan very regularly. I just came back from Quetta and I did this thing. So I think right now, this is not the thing. So genetic factors are not that much a part of it, because we have the similar population here in UAE. Same Pakistani Indians are coming to us, okay? And we are giving them a thing. The factor that the baby born somewhere and transferred to the tertiary care center is the main factor, is the one of the main factor. And the other thing is that the concept of the weak baby in the weak womb is the very, and I talked to many people in that study Helix trial, and then we have a debate in last 2023 hot topics where Dr. Sita Sankran, where everybody was there, and we all come to. So my point is that for the time being, as Khalid mentioned, if we don't have, we should move toward that. But until that time, if we do the basic, of neonatology. Maintain the glucose, maintain the carbon dioxide, maintain the electrolyte, and Professor Haque said about nutrition in the sepsis, but the nutrition in HI or neonatal encephalopathy. So we can do a better job without cooling. Because cooling at this point, we discuss a prolonged period, and there is a big, very good article published where all the major authors are there, and from Pakistan, Professor Zulfikar Bhutta was one of the authors, and they all recommend the same, that if we do the basic neonatology and try to maintain those things, the baby can better off. Remind you the newer studies about the severe encephalopathy who get the cooling is not coming that very great. Moderate encephalopathy who get the cooling is a little bit better results. Okay, so we are have to be very, very cautious if anything about those type of management we when we talk about in our setting in Pakistan. That's my whole comment about that.
Thank you, Dr. Junaid. I think we are a little over the time, and we'll move forward and for a break now, so that we can continue with the our conference. Dr. Sajjad.
Yeah, thank you very much.
Thank you.
This is Dr. Sajjad.
Oh, sorry.
Thank you, Dr. Shahzad and Professor Shireen. And thank you very much, Professor Khalid Haque and Professor Khalid Terkawi, for your excellent presentations and question answer and a very learning session. We have 2 minutes break, and then we start with the next session, which will be moderated by Dr. Muhammad Riaz, consultant neonatologist and assistant professor in Pittsburgh, USA. And the co-chair of the session is Professor Suhail Salat from Department of Pediatrics, Khan University Hospital.
Go ahead.
Okay. Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Welcome back to the second session of this virtual conference today. And our next speaker is Professor Huma Shiri. She will be talking about pain management in the NICU. Dr. Shiri is a professor, consultant, University of Alberta. Right?
Sorry, I'm not a professor. I'm an associate physician, clinical lecturer. Sorry.
Okay, that's what Dr. actually suggests. So I'm just reading. It's the University of Alberta, Canada. And she has been a frequent visitor to Pakistan for teaching and training purpose. Dr. Huma, speaker to you. Yeah, mic to you, virtual mic. Mm-hmm.
Okay. Assalamu alaikum to everyone. Sorry, I'm post-call, so I may be sleepy a little bit. So please ignore me. And it's like 6:50 a.m. in the morning here in Edmonton. So my topic for today is the neonatal pain. It's wait a second. Yeah. Is understanding, implication, assessment, and management strategies. I will talk on those topics. So the nature of our agenda is we'll talk about the physiology of the neonatal pain, its clinical implication of acute and repetitive pain, assessment methods for neonatal pain, and strategies for managing neonatal pain and future directions. I don't know why my screen is, sorry, there is some problem. I cannot. Okay. So what is the pain? According to International Association for a Study of Pain, they revised their criteria in 2020 also, that any unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage is pain. But in newborn, there is a limitation because they don't verbalize the pain. So the assessment of actual damage or potential damage is quite tricky. The historical background of the pain in neonate and fetus goes back to in 1980s, when there is a major understanding is that the neonates cannot perceive the pain because of immature cortex. From 1990 until 2010, they did realize that yes, fetuses and premature neonates can perceive pain until their late second trimester. It's very recently in 2020, it was evidence from the research that even the neonates who born less than 24 weeks can perceive pain because of their other subcortical connections to the cortex. The facts. From birth, we all know from birth to the discharge of a newborn, a healthy newborn has been exposed to various painful procedures such as blood sampling, immunization, vitamin K injections, circumcision. While with the advancement in the neonatology, we are seeing more premature babies admitted to the NICU. In those premature babies, if they are otherwise healthy, the regular pain frequencies are around 70 to 20 per day. If they are sick, there will be more extended stay in the NICU. There will be more invasive, non-invasive, painful procedure. And if you can imagine, if they stayed for 40 days, you can imagine in a single day, if it is 17 to 20, how many painful procedures and painful experiences they have to go through while they're staying in the NICU. When we classify pain, the pain are classified into diagnostic, therapeutic, surgical, and also according to the intensity of the pain, mild, moderate, and severe. Mild pain is related to like IV, access puncture, heel poke. There could be also pain also related with the stressful events also, such as diaper change, handling, light, noises. These can also sometimes stressful events which can lead to painful impact as that of the other painful procedure. If we talk about the major procedures, those are related to circumcision, cardiac surgery, congenital anomaly repair, laparoscopy, thoracoscopy, and in moderate category, these are intubation, PICC line insertion, lumbar puncture, ventricular taps. There are myths about the pain. Do neonates feel pain? Most of the perception is that they don't have the functional thalamocortical connection, so they cannot feel the pain. Do they have sufficiently developed neuroanatomical and neuroendocrine system to allow transmission of painful stimuli? How can we assess the severity of pain in a non-verbalized neonate and the response of analgesia in a preterm and term babies? Do they ever remember pain when they grow older? What are the long-term effects of prolonged and severe painful experiences? To understand better about do they feel pain, we need to understand, yes, they do perceive pain. They do have functional nociceptive pathways. Though their nervous system are immature and transitioning towards mature network connections, but they do feel pain in a different manner because of immature modulating inhibitory pathways. Therefore, it is very important to understand the neonatal pain physiology and to customize the pain management strategies for effective newborn care. We know that the theory of network connections in newborn is divided into two types of connections. One is the thalamocortical connection, which is the mature connection, usually acquired around 24 weeks onward and fully matures by the time of term delivery. And the other theory is subplate modulation theory. That is important for the babies who born less than 24 weeks or for the fetal brain. However, the pain receptors do develop around the first trimester, initially around the perioral area, and then by the end of first trimester, all of the cutaneous area and the visceral area do have pain receptors. From the first trimester onward, there are spinal cord connections to the brainstem and thalamus, and that connection landed into cortical subplate and then cortical plate around the end of 24 weeks. What are the differences in pain experiences between neonates and older children? There are multiple differences. One is the pain sensitivity differences. The neonates has large receptive field, resulting in low pain threshold and poor pain localization, such that noxious stimuli to the food, for example, may be perceived as affecting the entire leg. They have heightened pain sensitivity due to the immature inhibitory pathways. With the repeated procedural pain early in the life, they have alteration in the sensory function, which resulting in hyposensitivity following acute pain in neonates, and then later turned into hypersensitivity. And there is a difference in the sex prediction, females being consistently more sensitive than the male counterparts. There have been several studies being done, especially in the premature who born around 26-week gestational age, and then who had gone through the surgery. They have seen that they have followed those kids around 8 years and 19 years of age, and they have seen that the male preterm babies who had surgery, they have hyposensitization at the scar area and also hyposensitization of the thermal stimulus versus the female who have more hypersensitivity at the scar area and more hypersensitivity to the cold stimulus. So that shows that in the long run, their sensory functions became altered. Apart from the pain sensitivity, their expression is also variable versus the older children. Their behavioral expressions and physiological cues are subtle and immature. So if you don't focus on the neonatal behavior, like facial grimaces, cry, state of arousal, you would not be able to assess the pain implication on these babies. Therefore, there should be a specialized assessment tools available. It should be validated, not only for the term babies, but it should be for the preterm babies, for acute pain, for prolonged pain, post-surgical pain, and for chronic pain, for effectively manage these painful experiences for the prevention and of the morbidity in a long run life. What are the immediate impact of pain? It could be physiological, behavioral, hormonal, and psychological in the form of tachycardia, hypertension, tachypnea, desaturation, increase in intracranial pressure, changes in the cerebral blood flow, may be associated with increased risk of IVH and PVL, increased stressor responses, epinephrine, norepinephrine, glucagon, cortisol, which can all related to, in the long run, cortisol down regulation and risk of inflammatory diseases, IBD, chronic pain, fatigue. And then also, we should also do not ignore the parent. They would also be very stressful by seeing their babies going through these physiological changes during the intubation, handling, poke, IV poke, access, PICC line insertions, umbilical line insertions, and the stressful responses to the baby. It has been seen that the stressful parents' interaction with their own babies are also impaired. So the overall effect in a baby soothing related to parents' involvement would be less. What are the altered hypothalamic pituitary adrenal axis dysregulation? As we know, with the stimulation of the sympathetic innervation, the physiological changes we already talked. There will be hormonal impact with the release of insulin and glucagon ratio, and the stimulation of the adrenal cortex and the release of norepinephrine, epinephrine, and glucocorticoid. All these effects will lead to increased energy metabolism and increase production of reactive oxygen species, which we all know can lead to inflammatory reactions and decrease in the modulation mechanism. Along with that, at the hypothalamus level also, there is a corticotropic releasing hormone secretion, which will ultimately release to propionmelanocortin secretion, which cleaved into ACTH and beta endorphin. We all know beta endorphin is kind of protective mechanism. It suppresses the pain perception. It binds with the opioid receptors, but in a preterm babies, because of the excessive response of stress hormones, the endorphin is imbalanced. Therefore, they do not have the abilities to modulate their pain. What are the long-term consequences of unmanaged neonatal pain? These are variable depending upon how many painful procedures baby has gone through. Gestational age, like extreme premature babies, have more impact. What are the normal genetic variations and the sex differences? What pathways have involved, HPXs, inflammation, neurotransmitter, and then the brain developmental growth and volume loss. All those factors depends upon the long-term outcome in terms of impaired motor impairment, cognition impairment, behavioral impairment, and then ultimately executive functions derangement. These factors can be modified by improvising the environmental factors and involving the parents in the care of the baby. Long-term effects related to developmental delays. It has been seen those babies had reduced brain growth and structure, altered thalamic development, decreased frontal parietal brain width, altered diffusion measures and functional connectivity in temporal lobes, inverse correlation between frequency of invasive procedures and amygdala thalamus volume at 8 years in a babies who born very premature. Cognitive function derangements, these babies could have low intelligence, they have language and attention deficits, they could have poor visual motor function, impaired executive functions, poor behavioral outcome, and these cognitive deficits have persisted. It has been seen in the literature that these deficits have been persisted even when they reach to adulthood. And then preterm boys appear to be at greater risk for poor neurodevelopmental trajectories than their female counterparts. Behavioral issues, they would have internalizing behavior, social withdrawal, pain catastrophizing behavior, like magnifying the feeling of pain, feeling helpless, poor functioning, and poor academic performance. They could have anxiety, depression, stress disorders, chronic pain, altered perception, impaired tolerance to cold and heat, chronic fatigue. Somatic complaints are also more common: headache, diffuse body pain, pain and needle sensation. And this was, I literally experienced one of the premature who I met around like 5 years of age, and mom was quite upset that that baby had multiple IV pokes at the scalp because of the unsuccessful peripheral IV attempts. And later on, the girl developed pain and needle sensation whenever she combed her hair, the mom combed her hair, and she did not want it to comb her hair at all. These children could develop atypical behavior such as hypervigilance and exaggerated startle response, prolonged cry after immunization, heightened pain scores after secondary surgery, needing higher doses of analgesia. And in the long run, these developmental and behavioral issues can lead to serious health issues such as drug addiction, alcoholism, or obesity. We already talked about the altered hypothalamic pituitary adrenal axis development. This can continue into childhood and adolescence with the heightened inflammatory response, altered insulin-glucagon ratio, insulin hyperinsulinemia, and cortisol downregulation. We already talked about the altered pain processing and sensitivity, and the genetic factor also is involved in this altered pain processing. There are different genes involved. They have seen, especially in the boys, which are associated with altered pain processing. So in terms, this is the summary, like the painful experiences would impact in acute way and also in a long-term way to the all system of the body. What is the importance of early intervention? Timely pain management is critical for healthy infant growth and preventing long-term adverse outcomes. Accurate pain assessment is challenging but essential. Structured institutional evidence-based guidelines should be practiced with regular QI projects to assess the management strategies and effectiveness. Pain and non-painful stresses are also important to manage in units, as these behaviors are disruptive to basic physiological process and overall stability. Assessment tools should be multidimensional and age-specific, should be validated to detect all painful situations, like highly sensitive, able to discriminate between painful and non-painful situation, should be highly specific, produce the same result when repeated by different observers, help determine whether a pain relieving intervention was effective. So the question arises here, do we have any assessment tool which fulfill all the criteria? So far so, there are only few assessment tools which fulfill few of the criteria. There are ongoing research continue. We will see in future probably some more assessment tools. If we talk about the assessment tools, some assessment tools do check only behavioral, some check with physiological, some do check with neuroelectrical assessment, and some do check with hormonal responses. It has been seen in terms of, we talk about the hormone, the cortisol response with the pain experiences is high, but there is a setback because we cannot measure the cortisol. It will be another painful procedure and the level will come after some time. So the utility of measuring the cortisol for pain management is not very effective. Some researchers have been done saliva cortisol level, but also the quantity of saliva would not be sufficient to measure exactly the cortisol level. Similarly, in the unit, some units do not have the advanced electrical neuroelectrical monitoring like NICU or EEG. This is also not be a universal pain assessment tool at this point. So at this point, usually the behavior and physiological assessment is most common tools, which most of the NICUs are following. What behavioral indicators we have to see? Forehead frowning, brows drawn together, eyes tightly closed, nose flared bulging, cheek raised, nasolabial folds, mouth open, and the hands. So one hand is playing the fingers, the other one is fisting. This is also common behavior in a baby who is experiencing pain. The other physiological markers are, as we talked earlier, tachycardia, decreased saturation, increased cortisol level, and the electrophysiological monitoring. Frequently, there are almost like 40 assessment tools. I'm not going to discuss each and every. The most commonest three tools, we are using is Neonatal Infant Pain Scale, NIPS. The usage is around 23.9% globally. Premature infant pain profile at 43.9%. Neonatal pain agitation and sedation scale NPAS at 35 to 40%. Our unit in Edmonton and Calgary, we are using neonatal pain agitation and sedation scale. We have this is the added advantage because it not only assesses the acute, it does assess the continuous pain in ventilated, non-ventilated, premature, and term both babies. While the NIP and the PIPP, these are basically for the acute pain assessment tools. They both can be used for preterm and term babies. This is a small tabloid form where I mention about ALPS, Neo-Estrid Linder Lung Children Hospital tool. This used for prolonged pain in preterm and term babies. CRIES used also for prolonged pain. EDIN for prolonged pain. NIPS and PIP, as I mentioned, acute procedural pain. NPAS is basically for operative mechanical ventilation pain. Strategies for managing neonatal pain. So as we know, the neonatal pain assessment is underrated, and there is a variability in the management practices globally. Despite the high incidence of painful procedure performed in the NICU, most neonates receive no pharmacological analgesia or receive an inadequate level of analgesia. And there could be multiple factors which led to inadequate assessment and treatment of neonatal pain. It could be underestimation of the pain or concern for the potential adverse effects of the pharmacological management of the pain, like fentanyl, morphine-related side effects. Or it could be lack of awareness in the medical staff, or it could be staffing issue, like less number of staff. So there could be several barriers exist to implement the clinical practice guidelines. Therefore, adequate pain management is associated with fewer clinical complications and decreased morbidity. The evidence synthesized identified that the most frequently recommended pain management to manage the procedural pain is breastfeeding, followed by sucrose, then opioid and fentanyl, especially for the moderate to severe pains. What are the pharmacological intervention and safety consideration? So usually the two main category of pharmacological intervention after sucrose is analgesic and sedatives. In analgesics, fentanyl, morphine, acetaminophen, NSAID, topical analgesia, and in sedatives, midazolam, lorazepam, and dexmedetomidine. There are side effects for each of the medicine. and the side effects related with doses also and duration also. Like fentanyl, morphine would have tolerance and then withdrawal effects. Acutely, they can lead to hypotension, respiratory depression. Acetaminophen can lead to liver toxicity. NSAID is usually avoided for the babies who are having PDA, or it can also, small babies can also lead to necrotizing enterocolitis or the urinary impairment. Topical anesthesia can also be used for ROP examination, for lumbar puncture, for IV pokes, PICC line. Same is for sedatives, is usually used especially for the ventilated babies, quite agitated babies, but also there is a side effects of benzodiazepine in terms of hypotension, seizure-like activities, tremors. So non-pharmacological treatment is without any side effects. So needs to be very cautiously using those pharmacological management. But when there is a need, there should be guarded treatment. Non-pharmacological treatment, the more emphasis on that is swaddling, breastfeeding, non-nutritive sucking. Swaddling, they have seen in a review of 14 trials, they said that combining non-pharmacological intervention with swaddling is more effective than single modality. Also, some literatures check the infant massage prior to the procedure, which can also lead to less pain experiences, but the effect is of very low certainty. There are more research needed to see the actual effect of infant massage. Breastfeeding, direct breastfeeding, where the infant latches onto the breast and actively suck and swallow for at least 2 minutes before a painful procedure, is more effective in preventing pain than placebo or no treatment. Non-nutritive sucking, Cochrane review in a systemic review of 63 RCTs enrolling 4,905 infants found that non-nutritive sucking or pacifier in term and preterm neonates and improve the pain responses. Sucrose, one recent meta-analysis of 55 trials enrolling 6273 infants reported on the effectiveness of sucrose to reduce pain associated with heel length. Skin-to-skin contact also improves the bonding and reduces the neonatal and parenteral stress, and also regulate the temperature and heart rate. Environmental control, minimizing loud noises, bright lights, help create a soothing environment, reducing neonatal distress without medication. This is the algorithm we usually follow. So whenever there is a baby and we need to do an intervention, we have to see before the care and during and after that intervention care what needs to be regularized. Cluster care. So if we need to examine the baby, if nurse need to change the diaper or any procedure, mild procedure, painful procedure, the care can be clustered together. Always engage parents and family and minimize the painful procedure. That is the most important intervention. We can cluster the painful pokes in one time. We do not need to poke every 1.5 hours. And therefore, and then always try to vegetate the pokes if it does not need, like bilirubin check, hyperbilirubinemia assessment. We can do the transcutaneous check instead of poking for the serum bilirubin. PCO2. We can do transcutaneous PCO2 instead of, or end-tidal PCO2 instead of checking through the arterial gas if it is not actually needed or the baby is not severely sick. Assess the infant readiness for intervention. Infant stress agitation, provide time for infant to decrease and regulate the stress. If the baby is sleeping, don't intervene. Also, environmental factors should be improvised, like reduce the use of continuous sound noises, light cycle, and also scented clothes of the parents also improvise the stress responses. Coordinated care and intervention with developmental care teams. So if we decide to do the intervention, then the care should be associated with the developmental care team, such as assess positioning, always facilitated tuck, minimize arching, like always put a boundary surrounding the baby, make a natural flex posture, skin to skin care with the parents, hand hug, four-handed care. So the parents RT if the baby is intubated with the respiratory therapist or extra hand. Reassess the stress versus pain triggers. Developmentally appropriate interaction one at a time. So parent voice, gentle rocking, singing, humming, reading, visual distraction, infant swing, all can be addressed and can practice. Non-nutritive sucking, tactile stimulation, parent's hand, milk drops, OIT, oral immune therapy, sucrose can also be provided. What are the first line, second line, and third line intervention? So it depends upon the type of painful stimulus. Usually we use for circumcision if it is done. Here, mostly people do not go for circumcision in the initial neonatal age, but IMLA and sucrose can be given. Lumbar puncture, sucrose, and IMLA for more than 30 weeks. Helix stick, venipuncture, arterial stick, sucrose, PIC placement, sucrose. If the baby is intubated or on morphine or fentanyl, we can give morphine bolus. For PAR also sucrose and EMLA, chest tube, lidocaine, morphine, bladder tap, immunization, ROP examination. Like there, for each and every procedure, sucrose is most commonest people are using. Depending upon the other factors, like intubated, can use morphine. If it is a surgical baby, usually it is advised to continue with the acetaminophen round the clock, depending upon the minor, moderate, or severe kind of surgery. And we discuss about like minor, moderate, and major interventions are what are those. I'm not going to read each and every line. We can. So what are the recommendations? And these recommendations are from the College of Canadian Pediatric Society of 2024. Needle is related procedures.
नहीं मैंने कहा
Hello?
एनिमलियत
Sorry, hello? Okay, so the needle-related procedure, it was recommended that maternal and parent-led interventions such as direct breastfeeding, skin-to-skin care should be considered at first-line pain management. Sweet tasting solution combined with non-nutritive sucking may be considered as second-line management. Combining non-pharmacological intervention as adjunct therapy should be considered for essential comfort care. Tactile anesthesia should not routinely be used for heel length or phrenotomy. Topical anesthetic eye drop combined with sweet tasting solution, non-nutritive sucking, containment, parental presence or voice should be provided during eye examination for screening of ROP. Topical anesthesia you may use may be considered at the needle insertion site for lumbar puncture. Topical anesthesia should be used with caution in extremely premature infant who must be monitored closely for adverse effect. Topical anesthesia should be used in combination with a regional anesthetic block during circumcision. Acetaminophen should not be used routinely for treatment with procedural pain. Surgical pain, major post-operative procedure. Acetaminophen should be considered as post-operative adjunct therapy. All infants undergoing non-emergent laryngoscopy should receive effective analgesia. Opioid administration during invasive mechanical ventilation should be guided by a valid pain assessment tool. Continuous infusion intermittent bolus of opioid should be provided for surgical pain, major invasive procedure, and post-operative pain. Sedative agent should be used with caution if used should be considered as an adjunct therapy and not be provided alone as a sole agent. Midazolam should be avoided in infants younger than 34 weeks and currently not recommended. No recommendation can yet be made for the safe use of ketamine. Family involvement and supportive care is the most important. It develops the bonding and engages the parents in the pain management and improves neonatal comfort and emotional health. There are parents-led neonatal pain management review and update from the research and practice point of view, and they have seen that it has been scientifically proven that it is the most effective way of reducing pain. It's a cost-effective and culturally sensitive and can be individualized and tailored to both the parents' and infants' need. There are factors which are impeding the implementation of the parent-led pain care, and there are some factors which facilitate the implementation of parent-led pain care. I have gone through a few of the research which was conducted in Pakistan, which I will discuss later at the end, where they did notice the parents' perceptions in Pakistan related to neonatal pain or the management is not up to the mark, and they are reluctant to provide the care because of multiple factors. One is the unit area. Like usually unit is small. The healthcare workers are more concerned about the infection, sepsis, with the involvement of the parents in the routine care of the baby. There are lack of workforce in terms of nursing staffing. There is no unanimous standardized pain assessment and management protocols. And in this study, they have noticed what are the features which facilitate the implementation is the well-informed and empowered parent, professional communication skills, professional parent partnership, pain management guidelines like organizational, institutional pain management guidelines and protocols, educational program, pod talks, improve paid parental leave policies, family-centered NICU environment. All this made facilitate the implementation of parental-led patient care. So what are the clinical implications and future directions? We all know that effective pain control in newborn minimizes the risk of long-term developmental complication in later life and support healthier outcome. It reduces the hospital stay. It improves the developmental outcome, reduces the somatosensory impairment, neurosensory impairment, cerebral palsy, improves the delayed developmental trajectory, intellectual functions. There should be a standardized pain assessment tool and standardized effective pain management protocols in the unit. This is the Canadian study where they did implement the infant practice change resource guideline in a intervention effectiveness. They evaluated the intervention effectiveness and implementation effectiveness of impact. And they assessed the painful procedures Number of painful procedures. Procedures accompanied by valid assessment and evidence-based treatment, and pain intensity to determine intervention effectiveness using intention to treat and wait list analysis. So there are three groups. One group is for the babies who were subjected to that source and guideline and practice change intervention. And then another group is the usual care group. And the third group is the wait list group. Each group has 6 months. So interventional group was for 6 months. Then they went to the wait list. And the usual care groups directed to the interventional arm. So what they have analyzed that the interventional treatment group, the average number of painful procedures was lower in the INT group than in the usual group, usual care group. Pain assessment was greater in the INT group and pain intensity scores were lower. And same is in the waiting list group. So this was all over the Canada, 23 NICU was involved, and there was a good result outcome after the implementation of this infant pain practice change. There are ongoing research happening where they want to see is there any novel assessment tool, what is the safer analgesia, and what other non-pharmacological methods can be applied for minimizing the pain. One study was done in China, and it was done because we know for assessment of the pain, there is a nursing staff should be in adequate number. So to minimize the workload, they did a video-assisted pain assessment, and it was realized that in a real-world scenario, video-assisted pain assessment is an effective way to assess neonatal pain due to its high intra-rater and inter-rater reliability compared to observational on-site neonatal pain assessment. The other study, which is done in 2024.
Yes, Dr. Hama, you have 1 more minute.
Yes, I'm finishing. The other study, which was done in 2024, they look for the different biomarker for assessing pain and pain relief in the neonatal intensive care unit. And ultimately, they did find that, as I mentioned earlier, there is no specific biomarker available which is quick, which is quick to assess, which is to assess the pain, quick to assess the response to the intervention yet. This is their tabloid form where they check the autonomic, hormonal, proteic, metabolic, and oxidative stress, and did find validity or non-invasive timeless evidence procedural pain. And they had there's nothing available at this point except the autonomic and behavioral, which is a little bit more commonly used and more easily accessible. In Pakistan, there are a few studies which I mentioned earlier. They did in terms of parent perception, and then also relationship between the nurses training and neonatal pain management. And they did find the nurse who got trained and practiced the pain management strategies. The painful exposure is less, and the pain side effects were less in babies. So in summary, the importance of neonatal pain management is crucial for healthy development and reducing long-term health risks. Accurate pain assessment tools should be standardized and individualized, and the family engagement should be supported with emotional comfort and promotes better neonatal outcome. This is, thank you, done. This is my local park where I usually go for the walk. Thank you.
Thank you, Dr. Shiri, and doing it as on post call.
Yeah. Okay, I will have to.
Sure. Thank you, Dr. Shiri.
Yeah,
Dr.
I'm trying to unshare the.
Yeah, so there will be question answer session after the two talks, and then I think we will need you again there. Hopefully, you're still awake after the first call.
Yes.
Another 30 minutes. Dr. Sohail, are you there?
Yes, I'm.
Okay, you want to introduce the next speaker? Mm-hmm.
Thank you very much, the organizer, for giving me the opportunity, and also the chair of this session, Dr. Riaz, for giving me this opportunity. I'm going to introduce the next speaker is Professor Khurshid, and he is graduate of University of Damascus and currently working as a lead neonatologist at Alberta Medical Children's Hospital in Calgary, and he's also the director of the fellowship program there. And he is going to talk about the essential skill set operationalizing neonatal critical care training in resource-limited settings. Professor Khurshid, please go ahead.
Thanks, Dr. Sohail, and thanks for the organizer for inviting me to talk today to this group. And I had previous chats with Professor Sajjad and others from this group about the introduction of neonatal neuro-critical care in Pakistan on other countries, also the low and middle income countries. I'm originally from Syria, and I did all my training, pediatrics and med school in Syria. And then I worked in Saudi for a few years, and then I came to Canada to do neonatology. I ended up doing neonatal neuro-critical care fellowship after my neonatology, and then neonatal hemodynamics after that. And when I came back in 2013, I started the program of neonatal neuro-critical care. The point I wanted to make before starting my presentation that for us graduates from the low and middle income countries, we have something or some advantages over the Canadian and high income countries graduates. We have resiliency. We have a creative troubleshooting when it comes to challenging matters. And the unfortunate things, there are lots of narratives that got imposed on us that we are not able to do lots of things when they are not true, those narratives. Examples being programs like neonatal neuro-critical care, because we don't have enough money, we don't have enough resources, so we cannot establish cooling program, we cannot establish hemodynamic program. There are interesting paradox where things that makes money and bring money back to the high income countries, they got popularized in our culture. For example, most of us, we have smartphones and we pay lots of money to buy those smartphones. But when it comes to an EEG machine, we say, oh, no, we don't have money. This is not our priority. So the priorities, in a way, have been imposed on us based on the priorities of the high-income countries. So I challenge us to revisit that and see what matters for our patients, and then reorganize our priorities and really count on people and count of our ability to be creative and use what we have to reach results that even better than the high income countries. So why do we need a neonatal neurocritical care training program? So when I was embarking on this journey, I went with a group of us from Calgary and we visited one of the largest centers in Canada to propose this idea and pitch the the program to them. And the answer I got from those leaders was something like, I am not in a position to dictate on other programs how to train their fellows in neonatal neurocritical care. So we were shooed away from the table. And then I'll go to another program and I will be faced with something like, how can I help you? And if you are not familiar with the culture in Canada and United States, when somebody starts with the phrase, how can I help you? It means they are not interested in your proposal and they want you to finish as soon as possible. And things like, return your machine and see how can you get your money back, or this is not a real EEG, let's put a real consult and real EEG. So there's lots of discouragement, and always change is hard. So you guys, if anybody is embarking on starting a program like this, they will be facing with this challenging. They will be facing with questioning, skepticism, which is not bad in a way. It challenged the authenticity of your idea and how much you believe in it and how much you are passionate and how much you are willing to put your sweat and effort and time in it to implement it and make it the new norm. So some of these questions we tried to answer when we applied to the Royal College of Physicians and Surgeons of Canada and UCNS in America, because one of the things you need to answer is it needed, the new programs that you are trying to implement? So the first thing you need to prove is that there is variability in practice, and this variability in practice can be addressed with your proposal. To illustrate that, I wanted to present to you a case. This was Tegan. She had a severe HIE. She was at 38 weeks AGA, outborn, outside the tertiary center. She had fetal heart rate deceleration. Her Apgars were very low. Her court pH arterial was below 7. She had severe hypotension. She has placental abruption. She lost lots of blood. She required normal saline, O negative blood, inotropes. She was ventilated for 6 days. She had severe hypocapnia. The lowest CO2 was 23, and she had also persistent hypoglycemia. So in these areas, I can already identify areas of variability. For example, when to cool these babies. This was a straightforward case, but there are cases where they have criteria A, but borderline criteria B. At what time you cool these babies? Is 6 hours enough, or can we cool them at 7 hours? Or for outborn patients, can we cool passive on transportation? Should we use the servo control or passive cooling, etc.? Hypotension. What is the definition of hypotension? What is the treatment of hypotension? Ventilation for how long? Should we keep them ventilated? We used to keep these babies ventilated and not extubate them until after MRI. We need to extend their ET tube to make them accumulate CO2, because their CO2 will drop at the very low because of the metabolic acidosis and hypoglycemia. How aggressively should we correct the hypoglycemia? And then this kid had 28 electrographic seizures, and you can see on the right side that your EEG is becoming like ECG. And we know that the most common cause of seizure, acute provoked seizure in neonate, is HIE, and up to 80% of seizures in HIE is electrographic without a clinical manifestation. So without a brain monitoring, we are at risk of missing up to 80%. And this kid was an example. So how can we establish such a program and such expertise to be able to diagnose seizure? And then here MRI. So look at this. So this is an DWI. Bright is abnormal, means ischemia. So you can see all these bright spots in the deep gray matter and subcortical white matter. And this was classified as total asphyxia, meaning the center of the brain and the peripheral part of the brain is involved. And worse yet is when we counsel this family. So we came at the time, this was a long time ago when we were starting this program, we sat with the family and we have given them 100% chances of disability. So the trauma-informed approach when we counsel the family requires lots of attention, lots of sensitivity, lots of thought processing. And yet we sat with this family and we just gave it bluntly. We said, your child 100% will be handicapped, cannot walk, cannot talk, cannot drink, maybe cannot see, maybe cannot hear. So it's reasonable to redirect of care and switch to palliative, especially the baby still ventilated, CO2 is low, requiring inotropes, and the EEG seizures, you add them up, and severe brain injury on MRI. So this mom was single mother, was sitting there in despair, and her mother was sitting with her and not knowing what to do. They decided to go on and continue despite all the things that we have advised to them. And many of the mortality that links to brain injury is diagnosis driven, and ownership is on us. We come and we disclose to the family the severity of brain injury. We tell them the chance of disability is high, so it's reasonable to withdraw care. They trust us. We withdraw care. So when you read the literature about the mortality because of brain injury, just remember that many of those is because of us. We advise the family and the family trusts us. And guess what? When we look at the long-term outcome, we always combine mortality and disability. We say composite of death or severe neurodevelopmental impairment. So it is contaminated with our subjective decision of interpretation of the risk factors. So these are some of the areas of variability that I have mentioned: the identification of HIE, the neuroprotection strategy, the seizure diagnosis and management, the preterm and term brain injury classification and timing of imaging, the brain MRI in preterm infants. There's lots of debates about whether we should do them or not, the methods, the duration, the requirement, and the funding model for training in neonatal neurocritical care. This was a paper, two papers we published. We looked at the variability across the level 3 centers in Canada, and the pyramid on the left side, you can see there is variability across all the systems, starting with the identification of HIE, the neuroimaging, the neuromonitoring, hemodynamic management, respiratory, just go on and on. There's not a consistent management even in Canada or in US when it comes to the management and diagnosis of HIE. And the graph on the right side showing the outcome, also variability between the level 3 centers, and you can see that the variability persists when it comes to mortality, brain injury, or composite of mortality and brain injury. And this is in premature infants, they are no different. The graph on the left showing the difference and variability in the incidence of brain injury among centers in Canada and among countries participating in the iNeo network. There are lots of variability there. Now, the second question we had to propose to the Royal College and the UCNS is to prove that creating consistency in practice will improve those variability, will improve those outcomes. So we had to provide some evidence that having a dedicated neonatal neurocritical care program and consistency in care pathway will improve seizure diagnosis and management, will improve HIE identification. So all those areas of variability that I have mentioned, we went through them one by one, and we proposed to the Royal College, we proposed to UCNS that having a dedicated team will improve that variability and outcome. These are some examples from the papers that we published in our center after the initiation and the launch of neonatal neurocritical care. There are other centers that have published similar results, and this was the first study. The one thing I have learned from some of my mentors was that if you do something, publish it as soon as possible, because if you didn't publish it, it didn't happen. Especially with this program, when we started, we launched it, we started with a symposium, and we had the guest speakers and key players that will establish this program, from neurologists, neuroradiologists, and the epileptologists as well. So the first thing I had when we did this symposium, one of our leader in the NICU stood up and told me that you are trying to tell me that I need to be trained to be able to take care of HIE babies when I have been doing this for more than 30 years. And there was that skepticism. They were waiting for us, several of them. There were lots of supporters, but many leaders, they were waiting for this to fail. So when we trained our NICU nurses to put the EEG on, there were champions of us from neurology and neonatology, 24/7 available, looking for those EEGs that's set up by nurses and reading them. And we couldn't wait to publish this result, to showing that even this suboptimum service, we were able to decrease the anti-seizure medication. We were able to improve the seizure diagnosis accuracy. We were able to decrease the number of babies that they were discharged on anti-seizure medication. And that was the first publication from the program. And then we tested the outreach. We said we get only 20% of our moderate to severe HIE. They come from our tertiary inborn babies. The 80% of them, they come from centers outside of the tertiary center. So would having an outreach program improve the outcome for these HIE babies? And it did. We decreased the number of babies who are eligible for cooling and missed cooling from 19.5% to 4.5%. And this outreach program that had some online teaching, some in-person visits, some virtual and telemedicine, which is very much available nowadays, that we were able to decrease the incidence of mortality and severe brain injury in HIE babies that are born outside the tertiary center. And we compared ourselves to the rest of the country. We were the fastest to respond to the call, and the centers were the fastest to initiate cooling after the outreach program. And then we also tested the impact of the whole neuroprotection and neuro-critical care in the incidence of mortality and brain injury in HIE. And we showed that after the implementation of neonatal neurocritical care program, the rate of composite of death or brain injury decreased significantly. We did something called interrupted time series analysis to make sure that the change was due to intervention, not the change on practice over time. And neonatal neurocritical care program was independent factor in improving the outcome after adjusting for confounding factors. And the graph on the left I showed you before, the highlighted center is us. We were one of the lowest when it came to mortality and brain injury compared to the rest of the country. Now, you need to establish the service before embarking on training. So we need to have the service that is providing care for babies at risk of brain injury. You need to have the team, and then we embark on the training itself as standardizing of training. So when we reach that point, we send something called need assessment survey to see is there an appetite out there to start such programs. So there were 82 responders from 30 countries, and 29% they had completed neonatal neurocritical care, very few. But then 81% reported significant variability, just that like what I mentioned, and 88% were in favor of standardization of training. These are countries from around the world. Now, how can we, you and I, centers that they don't have neonatal neurocritical care program, we in Calgary, we are not a big center. There are centers like Boston, like UCLS, like UC. They are big. They don't need to standardize their care, to standardize their program. But medium-sized, small-sized programs, we needed a framework to establish the program. And these frameworks are built on pillars. You need a target population, you need the core personnel, you need essential equipment, you need clinical pathway, and you need a follow-up to measure the outcome and the impact of what you have introduced. The best disease and population, I would say, and this has been working for many programs, is HIE, because as I showed you, there is variability when it comes to HIE management, diagnosis, and outcome measures. And there are key players that they work together naturally, providing care to this population. So by working on HIE, you can use it as a case to build your program. And once you identify HIE, you see who are the key players, what are the investigations, what are the interventions that I can work in to reorganize my card, brand it, and start my service. And then the next step will be start the training program. The key players, I would say, are the pediatric neurology and neonatology. If you want to start a neonatal neurocritical care program, you need to start with neurology and neonatology. The equipment is EEG versus amplitude integrated EEG. EEG, we as neonatology are not comfortable. We look at those squiggles, we don't know what they mean, and we are a little bit hesitant in reading those EEG. Pediatric neurology, they don't like amplitude integrated EEG because it misses lots of seizures. Most of them, they don't know how to read it and how to interpret it. So there's this conflict between continuous video EEG and amplitude integrated EEG. And how can we bring those two worlds together to force these two teams to work together? So when I started here, we didn't have any form of monitoring even amplitude integrated EEG, to a point that they had to cancel one of the OSCE exams, which included amplitude integrated EEG, because the only center whose fellows were not trained in amplitude integrated EEG was Calgary. So we didn't have any. And when I came back, I was tasked to buy one. At that time, the two big companies, they were not one, they were Brains and Olympic, and we had some funding. I went to my mentor, was one of the senior epileptologists. I said, which one should we buy? And he told me, if you have a money and you don't have the car, why you go for a cheap car? Go for a Ferrari. So buy a full EEG. And that was I would say the best decision we have made, because having a full EEG, training our nurses, forced the pediatric neurology and neonatology to work together. We trained our nurses because they are at the bedside. They know how to take care of the baby. They understand their cue. They are very gentle with them. So they were trained to put a full EEG on, and they are putting full EEG on since we started the program. Now, the next critical question comes, what model? So we tried 3 models. We tried having a dedicated bed. So you have bed that's dedicated for neuro babies. That didn't work for 2 reasons. One, you cannot guarantee that this bed will be always filled with a neuro case, and you can't keep a bed empty, because the operation, the leadership of the hospital, they will come after your life. You say your NICU is not at 100% capacity. Why this bed is empty? On the other hand, some weeks you have more than 1 or 2 or 3 neuro babies, so you will be taking beds from the general NICU bed. So that didn't work. We abandoned that idea. Then we tried the model where you have a dedicated team doing a direct care for those patients and doing rounds every day. That also didn't work, because the composition of the team has epileptologists, has neonatologists, has pediatric neurologists, and they have other responsibility. It is challenging to have them at the same time rounding every day at specific hours. So that didn't work. And then we tried a consultation model. So we created a Neuro-Critical care and neonatal neurocritical care team, where they will be on the ROCA, they will be called, and they will look at the baby at their leisure time, they will examine the baby, then they will orchestrate the care. So having one-stop shopping where we communicate with the neonatal neurocritical care consult, and then they will communicate with the rest of the team, instead of having different and mixed messages from different multi-D team members. You are always communicating with one person, and that worked well. And this work in different settings, in big centers, medium-sized center, and small centers, and it will work in the low and middle income country settings as well. So since then, we had this neonatal neurocritical care and neurocritical care teams where they communicate and harmonize the care between the rest of the subspecialties. Once we have that established, now we use our HIE as a case. We built our framework, we built the structure of our service and program, and then we were ready to expand. And I always use the analogy of ultrasound. If you want to teach ultrasound to a novice who never touched the machine, you don't start with the heart. You start with something simple like bladder. You start with something simple like lung, and then you move to the head, and then you move to the heart, because you want them not to have a competing learning the interest. If they are trying to focus on learning the heart, they cannot understand or spend time learning the knowledge and the machine itself. Where if you are teaching them bladder, the task itself is very easy. So they can focus on learning the machine. Once they are comfortable with the machine, then you can move them to more difficult organ. And similarly here, by having a disease that we are naturally working together when we are taking care of it, and that is HIE, we can spend time building our program while the disease itself is not difficult to take care of. Once we build the framework and the program, then we can expand the team itself. So you have your obstetrics, you can expand the program, you have your follow-up, you can work on golden hour, you can standardize your neuroimaging and outreach program. And then you expand your clinical guidelines, you work on your education, QI and databases, and you start studying and publishing your paper. Now, what we did in the Newborn Brain Society, we created this task force that took on the mission of getting this service accredited by the Royal College in Canada and the UCNS in the US. And we had our education committee, which I chaired for 2 rounds, and then we have our accreditation task force. And we have now the discipline accredited by the Royal College and by UCNS, and the UCNS ran 2 exams. I set for the first exam, and then we put together the education curriculum as well. And the education curriculum is based on the core competencies. So we had to come up with core competencies. What are the competencies that required for any neonatal neurocritical care diplomat to be competent and be able to provide an extra care for this babies at risk of brain injury? So these were the core competencies that we published, and we have been following them, like neuroexamination, neuroimaging, neurophysiology, follow-up, genetics, etc. And then the final question we had, what model? Because there was variability in the model of training. Some will come and do PhD, masters, they will do research heavily. Some they were clinical more. And we decided to go with a hybrid of competency by design and a 1-year framework. So you can't go forever. And at the same time, if you don't meet those competencies, your year might go in a blink of eye and you haven't been trained in those essential the skills in neonatal neurocritical care. Who can come? Which stream? Pediatric neurology, because they can learn about disease-specific care, how to protect the brain while taking care of the heart and the lung. They can learn about the outreach program. They can learn about the implementation of bundles. And then for us in neonatology, MRI, continuous video EEG, having outpatient clinic, and both of them can benefit from the learning cranial ultrasound and amplitude integrated EEG. And these were some of the papers we published and some framework of how to approach each competencies. It can start with an online modules. They learn at their leisure time, and then you have simulation, you have just-in-time training, and then you have maintenance of competency. And by breaking it down in these small chunks and following these frameworks, you can teach frontline providers like nurses, like RTs, and you can teach each competency by itself and making sure they are meeting those requirements. And now the best part of it is innovation, because now with the blooming of AI and innovation, lots of things are becoming available at the hands of end users. And frankly, this is making the elite society freaking out, because for a long time they were maintaining their status because they were holding on to these advantages. And now suddenly the advantages is running away from their hands and becoming available in the hands of everyone. So I would say we should take advantage of that. We should jump on it. These are some of the examples that we have created of online modules of all competencies, and we made them available for free with CME hours from the Royal College of Physicians and Surgeons of Canada. We have created apps and we made them free for the brain injury diagnosis in preterm, and also for HIE cooling eligibility. That barcode will take you to a comprehensive care of HIE babies, including seizure management, parents guideline, HIE calculators, you name it, is all in one place, and it was created by few clicks, and that is thanks to AI and the availability of the knowledge. And again, you have to publish it. If you don't publish it, people won't believe it. So we took one of these simulators that we have created, a simple doll for neuro examination. And one of our graduate fellow who went back to India and established her own program, she tested that using her frontline nurses. So we taught the nurses a neuro examination using a traditional method by having a trainer teaching them on an actual baby. And then we also teach them using a simulator. Then they did an independent examination. They sent us the videos. We had the observers assessing their videos without knowing which group they were belonging to. And to our pleasant surprise, the simulation group were as good as the traditional group in the accuracy of the neuro examination. And even better, the retention over time was better in the simulation group. And our interpretation was because when they did the examination, it was not a stressful environment, so they were able to focus on the task, as compared when they are dealing with a baby who is fragile and is crying, the parents are there, there is the stress and urgency of time wasn't there, so they were able to retain the information. And suddenly this become upscalable. You can scale it up so much, because now you have a small doll, simple, that everybody can create, and you can teach everyone. As compared before, we had to wait for a sick baby with HIE that you need to train a 20 or 25 personnel on. That is impossible. That's where the simulation can bridge the gap. And innovation has no limits. So one of the stories that I had a girl who was born at home, and she had placental abruption. Her father resuscitated her, and that kid came to our unit. She was pale like a paper, and her neuro exam was very abnormal. The only thing in her examination was normal was pupils. And once we gave her blood, she flourished like a flower, and her MRI was normal. So since then, in my head, the pupils are the window to the brain. So I always make sure that I check the pupils when I do my neuro examination. So once I had a baby that I could not for my life open the eyes because he was edematous. So I said, what if I put a hockey stick probe and see if I can see the pupils using ultrasound? So we put a hockey stick, you can see the pupils are dilated. And then once I asked the fellow to shine the light on the side, you can see the pupils got constricted. And we published this paper. And now one of my fellows trying to use one of this machine to quantify the size of the pupils and reaction to light and see if we can correlate that with outcomes. And this is just the most recent ones that I have created. These are AI models that was able to differentiate between a baby who was very still, not moving, and telling you that this was stage 2 Sarnat, and baby who was active and said it was normal and give you some report. And it was also able to identify seizures. So there's chronic rhythmic movement. This is me with having zero experience in coding, and AI empowered me to create this research tool that we can eventually now test on real videos. And to Dr. Homa Shireen's point, she mentioned that the the tools that we have for pain are inaccurate, and she's absolutely correct. So what I did with AI, I took some of the available scoring systems and available AI publication, and I asked to create a code for an AI pain assessment tool. So this is the AI pain assessment tool. I will upload some of the pictures from internet. I'll see if it can differentiate between a baby who has no pain. So this baby clearly has no pain. So it says there's no pain, 90% confident, and say follow up routine care. And then a patient with pain, and it tells you that there is severe pain and you need to do something about it. And it breaks it down why it says it's severe pain. The eyes open, there's frowning, the eyes closed, and mouth is open and there's frowning, etc. So the sky is the limit with AI, really. Nowadays, it has opened up for us. I would say we should take advantage of it. Now, going back to Tegan, and I will close with this. Tegan, the parents decided against our advice to carry on. She has done so well that we discharged her early from our follow-up clinic. And every year she comes and visit me, and she send me some of these videos. This is her bragging about her swimming. And this is her with her family dancing, because they had more kids. And it always leave me wonder how many kids we made die because of our advice, and how many of them would have been normal like Tegan. And in a way, it takes a toll on me. It's a big responsibility. I am less certain when I counsel the family. It can go both ways. We can say the outcome is good, and then the kid will have severe disability and impact that family. It can be the other way around. It can be that the kid will be normal like Tegan. Can we differentiate between the two? I don't think so. I think we should embrace uncertainty and try to give choice to the family, put the table, the spectrum that they could have, and try to connect them with early intervention programs as soon as possible. So the need is clear, the process is manageable, the blueprint is proven, and the impact is huge. This is some of the fun that we have. These are my kids. One of the EEG setup training for nurses are putting EEG on my daughter. This is my son also. He wasn't that impressed with the training. This is my fellows learning how to put the EEG on my own head. That was a long time ago. You can see my beard was still black. And also this one of our nursing retreat where we were testing some of the commercially available EEG to see if they can focus or be distracted, some of the reading programs that we have. And I always like showing this video of my son reading EEG. When we started this program, we were 24/7 on because there was no EEG reading service. We were serving as troubleshooters. They will call me to the unit. I'll go and adjust the machine, and the machine will be on all the time in my office. So Ramin was 3 years old. He came and he said, "What you are looking at?" And he started to explain it. The brain's too tired. So in this picture also, I like it because Dr. Shireen present to you the micro image, when you have to focus on details. And then I showed you the bigger picture, and they can look the same. This picture on the right is from a place with a fall that comes to the trees, and you can see the trees are here and the fall is here. And this picture is another city close to my house where you see the Milky Way, and the Milky Way is like that fall coming to the similar trees. Both pictures are important, as important, but they give you completely two different perspectives. And I think we should never lose sight from both pictures. While we are working on the big changes, big systems, we should remember the family. We should remember Tegan. We should have this trauma-informed approach to these families when we talk with them, because what we say changed their lives. When we did some of the interviews with families later on talking about general movement assessments, the first thing they were bringing up without asking them was the disclosure of neuroimaging. One of the moms said she was suicidal. One of moms still have PTSDs from the memories of us disclosing this information without paying attention to details, without setting up the stage, without being there when we are talking. Is not one component or one task of the day. It should be the task of the day, because it will change the life of this family forever. Thank you very much. I'll be happy to take questions.
Wonderful talk, Dr. Mohammed. Thank you very much. Now we have the question answer session. And I don't see many questions over here in the chat box. So I will probably start with, I see Dr. Junaid has the question. For circumcisions, you have to have dorsal penile block plus sucrose. That's a comment. That's
a comment. Actually, for the first talk, I am just talking about, there are 2-3 things we have to understand. That first of all, AMLA for a very, very premature babies is not recommended nowadays because it can cause methemoglobinemia, and definitely not for the circumcision. Whoever the body recommend that, they have to review it, because circumcision is a very, very painful procedure. You have to have a procedure called dorsal penile block, in which you use the lidocaine. Even if you give locally the lidocaine, it will not affect the circumcision pain. So that's I have to say about that. Then other thing is, this is an excellent talk by Khurshid. He knows me very well, Muhammad Khurshid. He knows me very well, actually. He came, visited UAE. So the problem is the implement or implication or the application of all these things in our country, in Pakistan, is still, we are far, far behind it. So I think that we can start from somewhere very, very small things, and then we can reach there. So Mohammed, what do you think about that? You are also from Syria, I know you. So still we are very far behind with all these technologies and all those things.
I think we have, I can tell you when we started here, we didn't have any form, even amplitude integrated EEG in Calgary wasn't there. And the other thing we had to, the first thing they sent us to one of these big centers in the US to get trained for one day. And I think we spent $1,000 fee to go there for one day. And at the end of the day, I was one of our pediatric neurologists who led the program with me. When we came back, we said, well, this guy sold us water and air in bottles. They put air in bottles and they sold it because it was good in a way because we saw that we have everything. We have everything. We just need to reorder our card, reassemble the team and brand it. And then it was unimaginable when we started this, even in Canada. They were saying there's too many things, too many players. It's impossible. I think we have, if I put a percentage, we have 90% of what required to establish a neonatal neurocritical care program. And we have people who are resilient, who are creative, who knows how to troubleshoot. I always enjoy the videos I get still from Syria. I had the most recent one. There was a baby who had respiratory distress. They had CPAP, but they didn't have apparatus to put the CPAP on the head. You know what they used? They used a diaper. And it worked perfectly. It worked better than probably the $500 apparatus that we have here, and we sell it. I think lots of what the difficulties, the standing behind is ideas enforced on us. we can do way more than what we think we can do. That would be my take-home message. I remember there was a neurosurgeon came and visited us years ago from Harvard. He left his job and he went for missionary in Africa. So he said he will get these hydrocephalus babies with meningitis. He will put shunt on them. They didn't have good follow-up clinics. They will come back with really big heads, meningitis. So his method didn't work. So he started searching because he said there is nothing new under the sun. He found this method where you can fenestrate the third ventricle and cauterize the choroid plexus, and that way you can create a system without needing the shunt. So he went back to the US and the shunt companies. He convinced them to run an RCT comparing shunt versus his method. And guess what? His method was much better was comparable to the shunt without needing the shunt. So it became the standard. But the point I want to make, he came back to the US and he said, look, this is better. It's for free. Like, can we switch to this method? And he said, I got pat on the back. He said, this is good for Africa. We have our chance. We have our luxury. So we are attached to brands. If it is not Gucci, if it's not Jordan, it's garbage, even if the quality is the same. That is just mind-blowing for me.
Yeah, I think that's you. Whatever you said is true, but the problem is that we have to have a start from the basic neonatology and the basic setup. Our mortality rate is high. Our resuscitation things are still pending. We just develop our own resuscitation course. So all things we are working on that, and inshallah.
I think I lost you.
Yeah, I think we lost him. Do we have any other questions for Dr. Muhammad or Dr. Shireen? Okay. Yeah, I don't see anything else yet. So,
wonderful job, Khurshid. Really very impressive job.
Thank you.
Really appreciated and highly applauded. I am the chair of the Neonatology Group Pakistan Pediatric Association. So I would request Sajjad, who is the APPNA chair, so we can utilize your expertise and bring orientation to our group in Pakistan. We got a neonatology fellowship, we got a neurology fellowship as well. The thing is we need to collaborate between the two. The rotation of the neonatologist into neurology, and the neurologist should come to neonatology for a rotation. I'm giving you an example at Ahan University Hospital, we had maternal and neonatal unit. We got the feto-maternal department with the merging of both the department by moving house staff across the services. So same is the case, we can have rotation of the trainees across the disciplines, and we can use your expertise with umbrella of APPNA and PPA. We can definitely motivate people, and the way you motivated and brought the results now, we can have results from our part of the world. So Safdar, I would request if we can collaborate with Khurshid to bring some changes in our country.
I 100% agree, Dr. Suhail. The one thing, now we are starting even a collaboration with India, and we are starting to talk about having a collaborative neonatal neurocritical care between centers in India and Calgary. So they will come and spend part of their time in Calgary and then the rest of their time in their tertiary centers in India. So they are starting to talk about having the neonatal neurocritical care program training over there. And as you said, if we don't start, we will never move forward. We have to start somewhere.
I would just quickly comment that I cannot agree more. I think we can collaborate, and I think this is doable. And I'm really fascinated. I'm kind of AI guy. I am very fascinated with AI. I have, if you look at my phone, I have all sorts of AI applications in it. And you would not believe how many things you can do in minutes, which used to take years. And I think we should use technology to find low-hanging fruits in Pakistan. You don't have to have fancy, big budget things now. You can do easily very easily. And, there are developers in Pakistan which can help us with many things if we have innovative ideas. But I think this will take us away from our focus here. But I think, Dr. Salad, I totally agree. I think we can move this conversation forward after this conference and to find, to make a proposal how we can do conclusively like a collaboration in Pakistan and take help from people with expertise. But yeah, I mean, these are the kind of things which can make a huge impact down the road. And we are third world countries and we can actually fill this gap very quickly with the innovation. We have more population, we have younger population. They have all the mind into technology. We can utilize that. And we can actually go ahead of the game if we move prudently. And I don't want to take more time because this is an area which excites me way more. But I think this is we will continue this discussion after this conference, inshallah.
And even as Muslims, and we know that whoever saves one life saves the whole humanity, and whoever kills one life kills the whole humanity. And I always think of the other part of that coin. Like when I approach the family, I am scared now. Am I part of killing this kid if I am not accurate? So those are essential skills even for us as a Muslim to have. So we are delivering an accurate message, helping in sustaining one life. One life is too many. And losing one life is too many as well. So at the micro level is important, and the macro level is equally important, I think.
Thank you, Dr.
Any other question before we conclude our comments? Okay, thank you very much, Dr. Khurshid and Dr. Huma, for the great talks today. And do we have a break next, Dr. Sajjad, for a few minutes before we go to the next session?
Yeah, I think we can take a few minutes and then we'll start the last session of our conference, which will be chaired by Professor Junaid Muhib Khan, our very dear colleague and teacher and mentor from UAE. He's very well known. And co-chaired by Professor Talal Pakar from Pakistan. He is from Pakistan Army and recently posted in Rawalpindi. So it will be all over to Professor Junaid and Professor Talal. Thank you very much. You can start in 2-3 minutes.
Sure.
Thank you very much.
I think both the speakers are there in the group, Dr. Zain and Dr. Mohammed.
Thank you very much. Thank you, Dr. Sajjad and Safdar. Thanks a lot for inviting us, and so far so good. Excellent conversation, excellent topics you choose, and of course the speakers. Now, it's my pleasure to have the last session, first speaker, Mohammad Zainul Abidin. He's the assistant professor at University at Boston and Avidian School of Medicine. He's MSc in epidemiology, and he has his interest in long-term healthcare sequelae of the prematurity, global health, and the neonatal resuscitation. So the screen is over to you, Zain.
Thank you so much. Assalamu alaikum. My talk is on the retinopathy of prematurity, an updated perspective. I should also mention that, like the previous speaker, I'm also post-call, so please forgive me if there are any
it's okay, no problem.
errors. I'll start with a brief overview. I will talk about the my introduction, and I will just talk about definitions and epidemiology of retinopathy of prematurity. I'll talk about the management and my personal experience, my experience in fellowship and currently in training in my position, and then I will talk about global prevalence and then discuss Pakistan-specific data and prevention. For the trainees in the audience, I just wanted to introduce my story. I have an unusual pathway to medical education. I grew up in Pakistan. and then I came to the US for undergraduate.
Yes, डॉक्टर जैनुल आबिदीन इसको फुल स्क्रीन कर दिया।
Oh, अच्छा।
जैनुल आबिदीन इसको फुल स्क्रीन कर लेना।
ये फुल स्क्रीन हो गया या it's still not?
नहीं आई, अभी नहीं हुआ।
Okay, let's do it.
Then go from the slideshow here.
I'm going to stop the share for a second. Make the share going. Is this better? Oh, sure.
Yeah.
Is it better? Retinopathy of prematurity is the slide. Yeah, still not that slide.
If you click on that trophy sign on the bottom again, or press F5.
Trophy sign, it is pressed, but still not coming.
Yeah.
Same thing. Go up there in the slide, here, the file, home, animation, slideshow. Go
on
up.
the top.
On the top. Go back.
Go back.
And if you look
here
up,
is slideshow here. No. Here is the slideshow. Here.
Yeah. Still not?
No. Here is the slideshow here. You are not clicking, not this one, not this one.
Right
Go
here.
below, yeah, animation and then slideshow.
Oh, okay. Okay.
Okay, and then go to the slideshow from the beginning.
From the beginning.
Yeah. Oh.
Does that work better?
I don't think so. It's working anyway.
Let me just stop for a second and do it one more time.
Sure.
Yes.
Yeah, it's fine now.
Perfect.
That's okay.
So I will talk about thank you so much, everybody. So I'll introduce myself, and then I already went over the slide, so I won't spend any more time. But for the trainees in the audience, I have had slightly unusual. I've never met somebody who's had a trajectory like mine. So I think it is unusual. I came to the US when I was 18. I came to the US for college. I grew up in Pakistan. I grew up in Islamabad, and then I completed my college and did actually all my medical training in New Hampshire. I went to medical school and did my residency there as well. And then I did my neonatology fellowship in Connecticut at Yale. And in 2022, I finished and I moved to Boston, where I'm an assistant professor of pediatrics at Boston University and a neonatologist at Boston Medical Center, which is a level 3 NICU in Boston's public safety hospital. One of the best parts about my job is that I work with the residents from the Boston Combined Residency Program, which is Boston Children's Hospital and Boston Medical Center. So I really enjoy working with the residents and the fellows. It's an excellent residency. Boston Children's is one of the best hospitals, pediatric hospitals, and it's a lot of fun to work with the residents when they come over to our hospital. And I give this lecture to the residents and the fellows at Boston Children's. So I updated this lecture for our audience. So before I wanted to begin, I wanted to talk about what is exactly ROP. As most people in the audience know, it is a neurovascular disorder of retinal development that affects infants born before 28 weeks generally. Around 30% of at-risk premature infants, so the numbers in 2010 globally were around 180,000 infants developed ROP in 2010. It is quite pervaded. Around 65% of infants less than 1,250 grams at birth, and 85% of infants less than 750 grams will develop ROP. This is based on Oh, it's not for me. Um, um, when I think about a medical issue, I always think about, how it was first described. So ROP was actually first described in 1941. It was described, it was investigated because of increasing incidence of blindness, and it was identified by Theodore Terry in a cohort of US children. Subsequently, it was noted in a variety of contexts, especially in neonatal intensive care units, where there was a lot of exposure to oxygen. Steadily, the field developed, and in 1984, the International Classification of Retinopathy of Prematurity was developed, and it was a very global initiative and included 11 countries and ophthalmologists from 11 countries that essentially wrote the guidelines for what would be defined as retinopathy of prematurity. These guidelines were recently updated, last in 2021. Because the burden of retinopathy of prematurity actually continues to grow, or if anything, and actually the burden of retinopathy of prematurity has actually shown increase in both the high-income countries as well as low and middle-income countries, and it continues to be a leading cause of childhood blindness. Again, for the trainers in the room, I'm sure most of the neonatologists well understand, but just as a review for everybody, retinopathy of prematurity is a problem that develops from the vascularization of the retina. The retina does not have a blood supply. The retina gets its blood supply from initially from diffusion through vessels that are close to it. Retinal blood vessels emerge from around the optic disc, around the 14 to 16 week mark, and retinal vessels essentially develop from the optic disc and emerge outwards, and they cover the retina. They go to the nasal side first. Around 36 weeks is when they reach the nasal edge of the retina, and the temporal side, which is where the temporal bone would be, they reach around 40 weeks. So why does ROP happen? Although much has been studied and much has been discussed, it is still an area of active research. It is found to be a complex interaction between the retina and the immature blood vessels, oxygen tensions, and chemical signals. The idea is that the initial stage, there is prolonged hyperoxia, so increased oxygen supply to the blood vessels in the retina, which leads to a suppressing of the VEGF factor, which leads to a decrease in vessel growth. In the secondary stage, there is hypoxia, which then eventually, and also because of the halted vessel growth, there is a surge of VEGF, which leads to abnormal vessel proliferation. And these abnormal vessels can leak, bleed, or undergo fibrosis, and they can actually pull at the retina and cause the retina to be detached.
Zen, sorry to interrupt. I don't think so. Your slides are moving. Yeah, I think we are just on the one slide. What is ROP? Is that the same slide you want?
No, I'm in pathophysiology. Let me do one more time.
Yeah, if you go out of full screen and then maybe.
I'm in my office and I have a two screen model, and I'm wondering if that is what is wrong with this.
Yeah, probably. Yeah, sometimes it happens. It happened to me the other day as well.
Let me try one more time. Thank you. I'm so sorry.
No worries.
Is this?
Yeah, we can see, but can you move the slide? If you try to move it, can you go to the next slide? But it's not moving on our end. One option, I feel if it's a problem, we can just go without full screen, and that should be fine. I think the slides were visible, but not ideal. But I think that was still better than having one slide.
I can try to do that again. Is this okay? Is the slide moving?
I think
Yeah,
that's
this is okay
fine.
then. I think that's fine.
That's
Okay.
fine. We
You
can
can
go.
do without the slide share.
Yeah.
I want to slide share. Sorry about that. I will fix this. So this just is an image that shows what the pathophysiology of RP looks like. As you can see, this is what a normal retina, this is development of a retina. And this just shows premature birth and increased oxygen can then lead to decrease in a lot of these factors. And then subsequently, after from phase B, where the vessel growth stops, in phase C, all of these factors are then released a second time. There is a surge causing of abnormal proliferation of the blood vessels, leading to retinopathy of prematurity. So the risk factors, as you can imagine, would be related to all these factors that I talked about. So prematurity, low birth weight, supplemental oxygen exposure. Honestly, a lot of the things that we manage in the NICU, so RDS, IVH, PDA, sepsis, poor growth, has all been related to the development of ROP. I'll talk a little bit about, the stages of ROP. Again, for many people in the audience, this is something that they talk about probably every day when they're rounding. But just as a review for the trainees, the stage 1 of ROP is just a simple demarcation line where you can separate the avascular region of the retina from the vascular region, and I will have some pictures. Stage 2 is that line starts to thicken, so it becomes a ridge. Stage 3, you start seeing new vascularization, so you start seeing new blood vessels. And stage 4 is a partial detachment of the retina, when the new blood vessels, they start to thicken and they start to become more fibrotic and they start pulling at the retina. And stage 5 is total retinal detachment. This was demarcated in the first ICROP conference, which was in 1984. Subsequently, in 2005 and 2021, these were updated. Plus disease was introduced as a term also in the 1980s, which referred to dilated blood vessels. Pre-plus disease was introduced as a term in 2005, which was vascular blood vessels that were dilated, but not dilated enough to be termed plus disease. And then a new term was introduced called aggressive posterior ROP in 2005, which refers to ROP that doesn't really meet the stage criteria, but it is very severe and actually is located, as the name suggests, on the posterior side of the retina. So when people talk about ROP, they often talk about zones and stages. So the stages I already described above. Zones refer to which zone of the retina is being discussed. Zone 1 is right around the optic disc. Zone 2. And then zone 3. As you can see, the way to again, just that I always remember that both the right eye and the left eye, so the RE and the left E, LE refers to the right and left eye, and they're referred to as the faces of a clock. So 3 and 9 on both sides, as you can see, refers to the nasal side of the retina. And then the other side refers to, for on the right eye, the 9 o'clock refers to the temporal side. And on the left eye, the 3 o'clock refers to the temporal side. And the way ophthalmologists will describe the level of ROP, they will use these clock faces to essentially denote where the ROP disease is. This just shows a pictorial version of what I just talked about, which just shows stage 1 ROP, stage 2, stage 3, stage 4, stage 5. I have some pictures, again, just for the trainees in the audience. As you can see, this is stage 1. The first 2 pictures are stage 1. You can see a very thin line right here. Stage 2 is a thicker line, as you can appreciate right here. And stage 3, you can start to appreciate a neovascularization right here, and where these arrows are pointing. This is a stage 4 image, as you can appreciate right here. where you can see this is the retina that is essentially being pulled out, as you can see in picture number D. This is the retina that is being pulled. All of these are images of retinas that are essentially, it is being pulled from, it is being detached from its base. In stage 5 is complete retinal detachment. And as you can see, this is the optic disc is visible in this picture, and the retina has completely detached. This picture just shows what plus disease looks like. So from A to A, the green zone is a completely, that is how a normal development is. And then this is like a further scan of the blood vessels. So it goes from green to red. So red is plus disease, and so green is no plus disease. And as you can see, this is what a normal retina should look like with normal vasculature. And this is severe plus disease. As you can see, the blood vessels are very dilated. They're very tortuous. They're moving in all these directions. So when ophthalmologists talk about plus disease, that it's good to have a background when we discuss this with our ophthalmology colleagues, because it can affect when we offer treatment. Screening guidelines can vary significantly. Mostly in the global north or high-income countries, they are quite similar, although as this slide shows, they can sometimes be different. In the US, the general guidelines are to screen infants at less than 30 weeks or less than 1,500 grams, or if there is suspicion by the neonatologists and or ophthalmologists, at their discretion. For example, if the infant had severe pressure requirement, or even in cases of severe HIE. The first exam is done at 4 to 6 weeks or 31 to 33 weeks post-menstrual age, and exams are repeated depending on the severity of the ROP. I did want to give, again, the trainees in the room, like a sense of how these guidelines can change, even can vary throughout the world, even in the setting of an international collaborative, that is the ICROP, which you would think would mean that people would be much more unanimous in their suggestions. But as you can see in the UK, screening is at less than 31 weeks or 1,250 grams is what it's recommended. And Germany is less than 31 weeks and or births with less than 1,500 grams. A variety of countries don't really even have screening guidelines for ROP, but in this paper, I picked the one that they recommended that they had for India, which according to this paper that is cited, in India, the guidelines are for less than 34 weeks and or birth weight less than 1,750 grams. This is just, again, the US screening timeline. So if a baby is born at 22 weeks, they will recommend screening at 31 weeks. And then if a baby is born at 28 weeks, you do it later. So you do it at 4 weeks of life. So that means that the baby born at 28 weeks will be around 32 weeks. This just is a sense of just a sense of what to manage. So the management of ROP, as you can see, as I said earlier, the main issue is that the biggest risk factor is premature birth, and then the second factor is exposure to oxygen. So the way to manage ROP is to prevent preterm birth, but also to control the exposure to oxygen, to not let the phase 1 injury occur. And the treatment for phase 2, if the phase 2 has occurred and there is vascularization, then there are treatments that target either the retina or they target the VEGF factor itself. So as you can see, one of the treatments is to inhibit VEGF, which is after phase 2 has already occurred and ROP has developed. There are very good guidelines for the management of ROP. And so this is the recommendation for treatment recommendations by a large study that was done in the 90s and 2000s that recommended how to manage ROP. And so they defined it as threshold disease. And threshold disease was defined as when intervention must be done. And so they had type 1 and type 2 ROP. And so type 1 ROP was any stage with plus disease in zone 1, and then zone 1, stage 3 without plus disease, or zone 2, stage 2 or 3 with plus disease. And they recommend treatment within 48 to 72 hours because ROP can progress very quickly. For type 2 ROP, was defined as stage 1 or 2 in zone 1 without plus disease, or zone 2, stage 3 without plus disease. They closely monitor, sometimes as frequently as once a week, until the disease evolves and it requires treatment. So how do we treat ROP? So one agent that initially was developed in the 1980s was cryotherapy. So you essentially freeze the vascular peripheral retina that does not have the vasculature has not developed, and essentially that retina will then not develop vasculature and therefore will not be detached. It did show that it did reduce unfavorable structural outcomes. And so subsequently, this was further developed with laser photocoagulation, which, similar to cryotherapy, ablates the avascular peripheral retina and does not prevent further angiogenesis and disease recurrence. Laser photocoagulation is the current standard of care, because comparative studies between cryotherapy and laser photocoagulation demonstrated that cryotherapy led to poor structural outcomes, including myopia and more systemic complications. And so I have only trained with laser, and the next regimen is anti-VEGF. But I do know that in certain that I understand that cryotherapy is still offered in certain contexts. What I really like and what I really enjoy, and this really was something that developed during my training, were anti-VEGF agents. The available generic names in the US are bevacizumab, ranibizumab, and aflibercept. And the first two function as antibodies against VEGF, whereas the third option, aflibercept, is a decoy receptor that also binds to the VEGF and doesn't let it essentially promote further angiogenesis. It is used for type 1 ROP, and according to some meta-analysis, might have better outcomes than laser photocoagulation. It is given by an injection, so the eye is popped open and the medication is just given straight into the vitreous. It does, however, have at risk for disease recurrence is more common. And so the babies who undergo the treatment with anti-VEGF agents do require close monitoring. A large Cochrane review, which is always helpful, did show that although they reduce refractive errors, they do not reduce retinal detachment risk or overall recurrence when used as monotherapy. I will say that when I started my training, we used to do a lot of laser, and part of the job as the fellow was to actually be the anesthesiologist for these laser procedures. So a lot of time and hours was spent essentially managing the sedation for a baby undergoing laser therapy. In the middle of my training, we switched to anti-VEGF agents, and we stopped doing laser therapy. And I've been at my current job for around 3 years, and we have a significant amount of ROP because we take care of very premature babies who have very limited prenatal care. But we've not done a laser therapy. We've had quite good outcomes with our VEGF agent. So from our single center, we're quite happy with this treatment. And I personally am very happy because I do not like to be the anesthesiologist for a laser procedure. I'm almost at the end of my talk, so I'll talk about the global prevalence a little bit. Retinopathy prematurity is a high burden globally. Around a third of infants at risk will develop ROP. Low and middle income countries account for nearly 2/3 of all ROP cases. And one reason is that is what is termed to be the third epidemic. So the initial epidemic of ROP occurred in the global north, so the US and Europe, subsequent to just increased neonatal survival in the 40s and 50s. And then there was another surge when there was improved survival in, but without proper management of their oxygen needs in Latin America. And now the third epidemic is in sub-Saharan Africa as well as South Asia. And it is thought to be because of decreasing neonatal mortality rates, but also inadequate oxygen regulation. So babies are getting exposed to high oxygen, and more mature babies are getting exposed to higher oxygen. And also now that there's better survival of preterm infants, so now we're looking at survival of infants who are 22 weeks, even 21 weeks in certain contexts in the US, it has meant that more babies are not developing because there is increased survival. There is more ROP being seen in the high-income countries as well. So overall, the rate of ROP has actually gone up in both high-income and low-income countries for different reasons. When I was preparing for this talk, I found this interesting article that I just really liked, because it essentially talked about how retinopathy of prematurity has come back full circle in a way, because the initial description of retinopathy of prematurity was defined as fibrosis in the retina, and subsequently, it was developed quite well. For various guidelines were developed, but now in this paper they talk about a case of in India. There's a case report in India where actually the ROP was so severe that the vessel that had developed then just started dying. So they called it die back in, which previous to this case had only been seen in animal models who had been exposed to high oxygen. And these authors believe that this vessel dieback that was seen in this case, was actually what was originally called retinopathy of prematurity in the 1940s. So that is why the paper is titled that it's coming back full circle, because how it was originally defined is now being seen again in low and middle income countries. This baby was born at 30 weeks. And was 1,380 grams. So he did meet the criteria for screening, but he received 100% oxygen for around 7 days because there were no oxygen blenders. So now you're seeing more severe ROP because we are exposing babies to high concentrations of oxygen. In the end, I'll talk about a review of practices in Pakistan. There was a very good article that was shared in the APPNA group chat by Dr. Moeen that looked at severe ROP and assessment of ROP screening at a single tertiary care public hospital in Pakistan. It was an eye-opening article for me for many reasons, but in this article they had recommended screening at gestational age of less than 35 weeks and birth weight less than 2,000 grams. And nearly 9,000 infants met the criteria, out of which 46.7% were screened. There was a high infant mortality of around 40%, so that's why a lot of the babies were not screened. And a lot of the screens actually happened outpatient. The type 1 ROP rates were around 30%, and advanced ROP, so stage 4 to 5, was around 10%. They felt that the high infant mortality, the low follow-up, and inadequate access to care, such as oxygen blenders, was contributing significantly to the burden of ROP. The other article that I read for this talk was that I was wondering about anti-VEGF treatment, and that was introduced in Pakistan, and this paper came out this year. And so initially they were able to show initial regression, but there was it was only sustained in 40% of type 1 ROP patients, and all the patients with aggressive retinopathy of prematurity, the babies who were treated with VEGF treatment, this was around 60 babies. They all had it happen again. So the way we manage ROP is the prevention strategies are to carefully manage oxygen, but that can be very challenging in a setting of low resources because of lack of oxygen blenders. optimizing neonatal care. But again, that can be incredibly challenging in a setting where people have home births, where people do not have access to prenatal care. These are all incredibly challenging. Corticosteroids have been shown to reduce severe ROP. But again, for all the aforementioned reasons, that is difficult to achieve. That might be difficult to achieve in a low and middle income country. I know previous talks also talked about AI and using modern technology. And I will say that there is recently, in the past few years, there's been a lot of very interesting papers, and that do make me optimistic. So this paper is from this picture is from a paper that I've linked below, and essentially this is an iPhone, and they've attached a camera lens to it, and they've attached this head strap. None of this costs that much money. And this person is not an ophthalmologist who is taking the picture, but the camera is able to take a frontal picture of the back of the retina. The pictures got uploaded to a software program, and they were reviewed by the machine learning algorithm, and they were also reviewed by pediatric ophthalmologists, and there actually was significant overlap. And so this is in more remote settings or resource less settings. This could be a way to have increased screening, and then could be a reason to go more towards to be able to give access to care for babies to reduce the burden of ROP, and that I think does give me a lot of reason to be excited. I could not find any images like this in Pakistan, but I did find a similar study that was based in India. That is the end of my talk. I'm really sorry for the technical difficulties, but thank you again for the opportunity to talk here. I'm sorry that I'm post-call.
No. Thank you, Zainul Abidin. Inshallah, we will do the question answer session after the next talk. And it's again my privilege to introduce Dr. Talal Waqar, Professor Talal Waqar, my friend, long association with Talal, and we had many meetings together. Talal, over to you.
I think we have our next speaker, Dr. Abdul Rahman. He's from UK, South Wales, I presume. And do we have him around?
Yeah, I'm here, Dr. Talal, if you can hear me.
Thank you very much. And he's going to talk a lot about quality improvement, which is probably a cornerstone to progress in our part of the world. So the screen is yours, Dr. Abdul Rahman, kindly.
Yeah, let me just share my screen.
Sure.
Can you all see my screen?
Yeah,
we can see it. Thank you.
All right, brilliant. So my name is Dr. Mohammed Rahman. I'm currently a medical resident in the UK. I'm very honored and humbled to be a part of this neonatology conference. Obviously, I'm probably the most junior doctor here currently. Before I start, I'd just like to apologize in advance. I've been having some difficulties with the video sharing my face, but also I'm currently recovering from influenza, so I might sound a bit rough in my voice. So I do apologize in advance if I stop for a little breath. So today I just wanted to talk about the importance of quality improvement projects very, very quickly. It's something that we are currently highlighting in the UK as part of our residency programs, not just in internal medicine, but in general surgery, in pediatrics, in psychiatry, and in general practice as well. So I just wanted to begin this presentation with a quote from Dr. Paul Batalden, where every system is perfectly designed to get the results it achieves. So if your hospital or your community is designed to ensure the productivity and improvement in improving standards and enhancing the quality that patients receive, and you'll eventually receive those kinds of results. Whereas if your hospital or your community does not necessarily aim for those things, then you won't necessarily create a perfect design to achieve the results that you want to achieve. So the UK in 2023 implemented two quality acts as part of the NHS curriculum. One was to improve quality of healthcare services all throughout the UK, and the second one was to improve outcomes for patients overall in the UK, and this applied to various different specialties. So this applied to general medicine, general surgery, pediatrics, obs-gynae, psychiatry, and trauma and orthopedics as well. So I just wanted to start this off by actually discussing what is a quality improvement project. So a quality improvement project is typically described as a structured, data-driven program or method that ensures the goal to making patient care more safer, more effective, more efficient, and more patient-centered in various different specific settings. So this can include clinics, this can include hospitals, this can include outpatient general practice centers, and this can also include, nursing clinics as well as vaccination clinics as well. It doesn't necessarily just need to focus on hospital settings. So the main focus is, of course, on challenging your local processes and local guidelines and measuring whether those guidelines or processes actually improve outcomes in patient care. So typical examples that we tend to focus on, especially in the UK currently, where our A&E waiting times are at an all-time high, is aiming to reduce A&E waiting times can be an example of a quality improvement project that's identifying a problem. Or, for example, in practice with residents or practice with doctors, reducing frequent prescribing errors in pharmacological medications, etc., etc. So there's four main things that I wanted to discuss about how to sustain a good quality improvement project. So your main aim is to deliver care, not only in terms of benefiting a patient, but to also maximize positive health outcomes as well. And you want to avoid financial waste and also harmful environmental impacts, which we're generally focusing on, especially here in South Wales. So, for example, the first thing that we tend to focus on is prevention. So how do we promote health and prevent disease? By tackling the causes of illnesses and inequality. Now, in certain areas in South Wales or in the UK, you have areas that are very, very deprived. So your main aim is to promote health and preventing diseases by tackling those inequalities in those areas as well. The second thing is, of course, patient self-care. Now, as a professional doctor, as a medical resident trainee here, I think it's very, very essential where patients take a greater role in managing their own health and healthcare. And the aim for that is to ensure that they are empowered to be able to make their own decisions, but to also know what exactly is beneficial for them as well. By knowing what their healthcare and what their current management and their current diseases are, they get a better opportunity to not only protect themselves, but a better communication and relationship with their doctors as well. The third thing, of course, is lean service delivery. So streamlining care, implementing systems to minimize wasteful activities as well. We don't want to obviously use up a lot of hospital resources, including doctors, nursing associates, physicians associates, etc., etc. And the last thing, of course, is low carbon alternatives. So this is more focused on the environmental impact of a quality improvement idea. We want to ensure that our improvements environment as well, not necessarily just only benefiting patients, but also benefiting the environment and the hospital environment as a whole. So how do we do a quality improvement project? Well, there's a lot of different ways of actually doing it. However, over in the UK, we've kind of standardized a role that we want to achieve. So the three things that you have to ask yourself when doing a quality improvement project is, what are we trying to accomplish? So what is the aim of your quality improvement project? Sorry about this. Just need to move this out the way. Oh. So what are we trying to improve? Obviously, what are we trying to accomplish? Then we have to focus on the aim. So how will we know that a change is an improvement? How will we know that that implementation will potentially create an improvement in a hospital guideline or a hospital protocol as well? And then obviously the final step would be obviously testing the change, seeing whether those implementations will result in an actual improvement. So this overall causes something called the PDSA cycle, which is the main instrument that we use for quality improvement projects. So the Plan, Do, Study, Act cycle is what it typically stands for. So what do we mean by plan, do, study, and act? So plan is obviously defining the objectives, the questions, and the predictions. So who are we answering to? What are we trying to investigate? What is the actual problem? how do we plan all these things out? And then the do part of the PDSA cycle will be carrying out the plan, collecting the data, analyzing the data, assessing where the problems are, assessing the implementation, which involves the study act in the PDSA cycle. So this is when you start to analyze the data, compare the data to the actual eventual predictions, comparing the data to previous standardized data collection, and summarize what was typically learnt during your analysis of your data collection. And then the act is obviously the implementation of changes within your hospital policies, planning the next cycle, implementing new solutions, and deciding whether those changes can actually be implemented and whether they actually had a beneficial impact on your curriculum and on your guidelines as a whole. So what exactly are we measuring? Well, there's three things that we're actually measuring here. One is obviously outcome measures. The second one is process measures. And the last one is balancing measures. So outcome measures, typically, we look at links to change the system at a certain level. So this kind of relates to the aim. So for example, if we are aiming to reduce the weekly length of a stay on a typical ward by 2 days, by let's say June of 2026, then the outcome measure would be what we're measuring, which is the weekly length of stay in a certain number of days in that particular ward. A process measure is typically the steps in a process that leads either to a positive or a negative outcome. So that directly links to the PDSA cycle, as we mentioned earlier. So for example, if we're taking the example that I mentioned earlier, which was to reduce weekly length of stay in a ward by 2 days by June 2026, the process measure would be the number of board rounds per week. This would be your implementation, and that would be measured by the process measure. The final one is balancing measures. So balancing measures is the unexpected consequences or changes elsewhere in the system. So this, for example, are elements that may not necessarily be accounted for that may influence your outcomes. So for example, the number of patients being readmitted to the hospital, that may influence the number of days that they stay in a particular ward, for example. Just before I continue, I just wanted to highlight the importance on differentiating between a clinical audit and a quality improvement project. This is also something that I had recently learned about a few months ago. And there is quite a substantial difference between a clinical audit and a quality improvement project. So they have two different purposes. So a clinical audit currently measures your hospital's practice against the current standard guidelines. So if your hospital typically follows the UK guidelines, you'll be assessing the current practices against NICE guidelines. Whereas a quality improvement project looks at improving outcomes using specific, measurable, achievable, relevant and time-bound testings. Data collection for a typical audit is usually retrospective, so you're using data collection from the past, whereas quality improvement projects typically continuously collect data throughout time. So you're continuously collecting data as you implement changes to a certain curriculum. The data presentation is probably the most important aspect of a quality improvement project, because I think this is what... Sorry?
Sarup, can you please mute your... Sarup Chand, we will listen to you later on. Please mute for the time being. Let Mohammed present. Yeah, thank you. Mohammed, continue, please.
Yeah, thank you. Thank you, Dr. Junaid. Sorry. So, data presentation is probably the most important thing as to how you can reflect truly whether an implementation has positive impacts over time. So in a quality improvement project, you typically look at run charts or use run charts that display trends over time, whereas in a clinical audit, you would typically use bar or pie charts. In data analysis, clinical audits typically use a single set of data, whereas quality improvement projects use multiple data points that are collected over time to assess whether a change is improving a specific outcome. Audits usually typically have a larger sample size. A quality improvement project typically has a smaller sample size. Teamwork is typically variable. Some clinical audits do usually get involved with collaborative schemes with different departments, and cycles are usually similar as well. Usually you can have 1 or 2 with clinical audits, and quality improvement projects can also have 2 or more as well. So this is what I wanted to discuss mostly about. This is the result example here that I wanted to show. So what we can see here is that you have your chart, which shows your median baseline. So this is the performance that you can see here before your interventions have started. And then this, for example, will be the dates that you implement a change within a hospital policy. So, for example, you're assessing prescribing errors in a certain ward, or you're assessing the adherence of appropriate antibiotic duration for a community-acquired pneumonia. The change implemented here can show the improvement in numbers collected after that, and then you can kind of start to see the improvement go along with the run chart, and then you can collect data after that as well. So then you can start to see that the goal line, for example, will be the result that you are aiming for, and then if you're above that sort of line, then you're achieving your expected goals and durations and your predictions as well overall. So typically this is what we use here in the UK as a standard for whether something is typically improving in a clinical setting or in a ward-based setting. So to conclude, there's a very important discussion that I wanted to talk about. This is a case study that was very recently given in our hospital as well, where we had a 45-year-old male who had a past medical history of a splenectomy in 2014. He was brought in to Withybush A&E, which is where I'm based in currently, and he had developed an acutely worsening cough and signs of sepsis. This patient was admitted under medicine and was started on IV antibiotics and fluids, and despite not being initially stabilized, he went into ITU and unfortunately passed away within 24 hours from worsening sepsis. Now, typically you kind of see these cases quite often. However, the underlying predicament was that this patient had a splenectomy and was required, as per splenectomy guidelines and infectious disease guidelines, to adhere to appropriate vaccination protocols and antibiotic protocols. So during our clinics, we had noted that this patient was part of a cohort of patients who had a splenia or a splenectomy in South Pembrokeshire here in South Wales. He was among 30 patients who had a splenectomy, and he was found to not have been vaccinated with the influenza vaccination, which, according to the infectious disease and NICE guidelines policy, is required every year, especially for those who have splenectomies. And he was supposed to have an updated pneumococcal vaccination, which is usually given every 4 years for those who have splenectomy patients. And of course, he was not on appropriate antibiotic prophylaxis. Now, this was important for us as a community, as physicians, because this is a very preventable disease. This is a very preventable death. And the importance of trying to undermine what the problem was important for us to develop a quality improvement project around this specific issue. So me and my colleagues had investigated the number of patients who had appropriate influenza vaccines, appropriate pneumococcal vaccines, and appropriate antibiotic prophylaxis. And we had found that 33% of patients who had a splenia and splenectomies were not vaccinated with the influenza vaccine. 45% of patients did not have an up-to-date pneumococcal vaccination, and 67% of patients were not on appropriate antibiotic prophylaxis. Now, there is multiple reasons for this. I mean, hematology can get involved in this, oncology as well, infectious disease as well. However, typically clinical practice would indicate that these patients did have reminders for vaccination schedules every year, and that did not necessarily benefit the patients. So that creates a problem, and then you have to look at ways to improve that kind of clinical picture. So we implemented a solution to this using the PDSA cycle, where we wanted to improve care for asplenia/splenectomy patients so that vaccinations and antibiotic prophylaxis increases from the baseline, in which 33% were not vaccinated for influenza, 45% were not vaccinated with pneumococcus, and 67% were not on the appropriate antibiotic prophylaxis, to 100% of patients being appropriately vaccinated or on correct prophylaxis. So that would be the aim, the plan. And then the change part of the PDSA cycle would introduce a standard performer for first-year doctors or second-year doctors to systematically review these patients' vaccination status and antibiotic usage, and to contact them on virtual clinic days to discuss the benefits, risks, and needed actions for these vaccinations and antibiotics. So the junior doctors would be able to identify all asplenetic or splenectomy patients, review their records, and phone them to discuss their vaccination and prophylactic antibiotics. This will be the do part of the Plan, Do, Study, Cycle Act. And clear advice was given and appointments were arranged for vaccinations and to issue or adjust antibiotic prescription as they were needed as well. So then you have to look at the study aspect. So during this, we looked at obviously all these patients, which was a cohort of 30 patients. And we looked at the process and outcome data, which showed that after introducing the pro forma that was used by the junior doctors here in the UK with virtual review calls, 100% of identified patients attended for the vaccination and received appropriate antibiotic prophylaxis. And what the junior doctors in our community had learned from this quality improvement project is that many patients were not typically aware of the consequences of not being vaccinated, especially given their immunocompromised state, which is very, very essential, which kind of ties back into what I had said previously, where patients should be aware of what they typically have as their diseases progresses in order to ensure that they know the risks of not being vaccinated or the risks of not taking appropriate antibiotic prophylaxis. And also the junior doctors reported that the performer made it easier to remember all the key points and standardized practices with the infectious disease team and the NICE guidelines currently within the UK. So overall, the ACT, as part of the PDSA cycle, the ACT would have been the intervention, which includes the pro forma that we had generated, plus the virtual review calls during clinics, which was adopted as a standard practice for all relevant clinics here in Pembrokeshire, and added to introduce this as part of the junior doctor curriculum for training in their clinical practice and clinical teaching sessions. Not only does this improve their communication skills, but this also overall improve their ability to understand the relevancy of adhering to a vaccination schedule and antibiotic schedule. So that was the biggest aim that we had done for our quality improvement project on the PDSA cycle, and how we have to ensure that these kind of things should be implemented in order to prevent cases like our 45-year-old male who had unfortunately passed away because of the fact that he did not have the appropriate vaccinations and antibiotics in this situation. So my final message to all my healthcare colleagues is that healthcare workers always have two jobs. That's one, to do their work, and secondly is also to improve it. We're not just here to treat the patients, but we're also here to treat the hospital and ensure that they improve their guidelines and improve their quality of care. Thank you very much.
Thank you. Thank you, Mohammed. You said that you are just a medical resident. I myself a quality guy, American board certified, and the CPHQ also. I am saying you without any hesitation, you have a very excellent presentation. It's a remarkable, and how you present your case and organize your slides is excellent. Keep it up, the good work.
Dr. Junaid, thank you so much. I do apologize, actually. I was very disappointed because I'm very, very sick at the moment with the influenza. There's a current epidemic here in the UK.
Yeah,
I'm very, very thankful for your words.
No problem. You did a great job. And for your influenza, make a black tea, put 2 sachets of Joshanda, which has acidity, which will relax you. Okay?
I've done all of that.
Nice.
Thank you so much.
I ask Talal to start the Q&A session, please.
Okay. You will get Joshada from ESDA, I'm sure. Okay. You yourself are smoking with a good cigar in your mind. Okay. Just wanted to thank you very much, both of the speakers, and I think we can have some question-answer session. Just a brief comment from my side. Thank you very much, Dr. Zain, for pointing out very nicely about the ROP and its development. Interestingly, we started off in, I think, 2013 or 2012 with Pakistan Society of Ophthalmology people, Dr. Umar and Dr. Moeen. Dr. Umar is residing in USA, and Dr. Moeen is in Lahore. They are both ophthalmologists. They developed a consortium, and which was named as ProPera. And in collaboration with the neonatologists of this part of the world, I was also one of them. We had developed guidelines. The only difference was that we've done some preliminary data. Based on that preliminary data and some pilot studies and some data from India, we increased the gestational age to 35, as well as the birth weight to 2,000 because 2,000 grams. Because we were seeing a lot of ROP in bigger babies also. So that is one difference of guidelines. I can share it with you now on this chat box. I have those guidelines with me. And Alhamdulillah, I think hats off to the Ophthalmology Society. They are doing a tremendous work on it. We only provide them one of the input of babies that we give to them, but it's their task that they are doing it very nicely. We are open to any questions, and we'll be happy to address it to
Yeah, Talal, I have a question for Zain. Zain, you talk about very nicely about the ROP and stages and everything. Two questions I have. First thing, during your talk in prevention of ROP, you didn't mention the most important prevention about the breast milk, mother's own milk, how it prevents the ROP. And the second is, forgive my stupid question because this term is a relative new to me. What is the posterior aggressive ROP?
Well, no, those are both good questions. Thank you, Dr. Junaid. And before I begin with Dr. Talal, the paper that I mentioned at the end from that looked at the ROP in Lahore was actually from Dr. Moeen's group. So, and that had the guidelines for less than 35 weeks and less than 2,000 grams, which are guidelines that I agree with. I think because we have more aggressive oxygen, depending on the setting of the baby's born in, I think it makes sense to have a larger, a higher threshold.
In fact, there is a lot of data from India which says that even in this part of the world, the bigger babies are more exposed to it.
Yes, exactly, and I think they're getting more severe ROP, and that was something that I talked about in my talk. And yes, Dr. Junaid, I agree that I think supply good nutrition. So I think like babies who are able to with obviously important role of maternal breast milk that are able to show have improved outcomes for ROP, and I think as I was reading this talk, I found papers and protocols that actually were looking at weight gain as a factor for determining which babies get screened for ROP, and changing the metrics a little bit depending on how your weight gain was in the first month of life, and other factors also becoming a factor for when you would get screened for ROP. So I think in a few years the conversation will likely change, and we will be looking more closely at weight gain. And then aggressive retinal. Yes, we should promote the use of blenders, because then I think you can titrate the oxygen. That was something that in the global north, in the US and Europe in the 40s and 50s, the initial high rate of ROP was because babies were getting a lot of just 100% oxygen, and then with the advent of blenders, that was adjusted, and that therefore the rate decreased, but then the rate increased also because there was more survival of extremely premature infants. And then aggressive retinopathy of prematurity just refers to so that's I won't try to share my slides again because I feel like it already was a disaster the first time around, but essentially it refers to retinopathy of prematurity that isn't really in a particular it's very aggressive. It doesn't really follow the stage format. So it's not stage 1, 2, 3, 4, 5. It's just like very neovascularization that is very fibrotic and develops very aggressively. And so that is a relatively new phenomenon introduced around 20 years ago, and is being seen more and more commonly, especially in places like India, Pakistan, Sub-Saharan Africa, where you're getting ROP that is not following the conventional 1, 2, 3, 4, 5 stages in these discrete zones. So I can send a link to the chat about that also.
Thank you very much. Thank you very much. Very grateful. Anything else? Anybody has a burning question before we then wrap it up?
Talal, on a lighter note, because we are, closing the conference, I have one general knowledge question for all of you. Who is the famous singer in America who will get blind because of ROP? Let me see who knows this thing. Sajjad?
I don't know the answer.
Give us 2 minutes and we'll ask ChatGPT.
Not the ChatGPT. It is a very famous thing, and it is a lot of articles after that. It is, I just call to say I love you. It's Stevie Wonder is the very famous singer who got ROP and he got blind because of that. Anyway, if no further
somebody
question,
I think just give Dr. Sajjad Nazir wants to ask some question. He said,
yes.
Just I'll unmute you just a minute. Yes, sure. Now you can unmute yourself. Dr. Sajjad Nazir, please.
Assalamualaikum. Thank you very much, Brigadier Talal, for giving me a chance. I've got a particular question with Zan that, like in Pakistan, we know that almost more than 80% of the hospitals, they do not have the blenders and blended oxygen. And we do see a children, like a baby is born at 35 weeks with meconium aspiration, or a baby with the IDM and RDS. And at 35 weeks, they are blown up with this 100% oxygen for 2 weeks, 3 weeks, and they are out of the NICU for after 3-4 weeks. So in this bracket from 35 weeks above, there is another term which is called retinopathy of prematurity like retinopathy, ROP like retinopathy. And as you have mentioned in your talk, that the neovascularization on the temporal side still exists up to 40 weeks, and on the nasal side is 36 weeks. So my question particularly for this group is, which is not even in the ROP screening program in Pakistan, less than 35 weeks in 2000. What about these babies who are on a very high oxygen, especially on the DIY type of a CPAP, which is 100% oxygen, and these babies stay longer on oxygen? What about these babies, although we know that retinopathy of prematurity like retinopathy mostly have got genetic component and other diagnoses, but do they have the effect of this high oxygen, and whether they should be screened for the ROP or not?
I'll just answer, Dr. Zain, you can answer it with it. These guidelines which are developed, they do include these babies, because if you read these guidelines, the second point is that all those babies who have had prolonged stay and have had oxygen requirement, they should be screened. Dr. Zain, your take on it?
I think I would agree. So for example, if you have a really bad case of HIE and I had a very aggressive resuscitation, and then the baby's on pressors, I will have the ophthalmologist screen that baby, for example. So I think in this case that you're referring to, I think if a baby has had high exposure to oxygen and the eye is still developing, I think it makes sense to screen. I think you will likely see that there is some maybe evidence of ROP. Hopefully not severe ROP, but you might still see like some evidence of it if you screen these babies. I think even in the paper that I mentioned with Dr. Boyne, although they identified almost 10,000 babies, in the end only half of them were screened, because many of them died, but many of them also didn't come for the screening. So I think if you do more screening, I think you'll see more evidence of it.
Sure. If no more question, back to you, Sajjad. Dr. Sajjad.
Thank you very much. Yes, Dr. Sarabchand. Dr. Sarabchand has a question, I think.
No, it's just mic open. Okay.
Okay. Thank you very much, Dr. Junaid. Thank you very much. I really appreciate. Thank you, Professor Talal. It's very kind of you to be coming and participating and honoring our conference as chairman and co-chairman. And thank you, Dr. Muhammad Zainul Abidin and Dr. Muhammad Abdurrahman, for your excellent presentations and the knowledge you have shared with us. It was really, really very useful for all of us.
Thank you so much.
I really welcome, sir. Welcome. It's nice meeting you as well.
Yeah.
Thank you very much for all the participants, and I appreciate your number went to more than 88 at one point. And I appreciate for all those who have been bearing with us for the last 4 hours or 4.5 and 5 hours. And they have been sitting, and it shows the interest of the audience as well. Thank you to Dr. Safdar, Sultan, and all colleagues from APPNA Pediatrics for their wonderful support and the participation by our APPNA Pediatric colleagues and all the speakers who came up with on a very short notice. It was only a month's time that we started preparing for this conference, but within 1 month we were able to make a very good one-day conference. And inshallah, next year we'll make even a better conference than this one. Thank you very much. Dr. Safdar, you can close the conference now.
Inshallah. No, thank you, everyone. I think this was a wonderful session. All 3 sessions, they went really well. To be honest, I was a little nervous how we can handle it, but I think it went really well. Yes, we should continue every year. I think we will get better with time. There are just a couple of housekeeping points that we will upload these videos to our APPNA Peds YouTube channel, and just not probably until next few weeks. So we will have to edit it, remove those silent areas, etc., and then we will upload. And and we will, I think, one thing I wanted to get out of this conference is to find opportunities for collaboration. And one thing is like we can actually work on training our fellows and residents on quality improvement projects. Just like Dr. Junaid mentioned, the last talk was really excellent by a trainee. So I think we should train more people, and I was really impressed with that. And then, some of the things we can do as a low-hanging fruit, for future to collaborate. For ROP is one of the areas, for example, we can collaborate. The other one we talked about with Dr. Sultan is the Neuro-Critical care. We should find avenues to collaborate. I think those discussions will continue even after this conference. And trust me, behind the scenes, a lot of efforts takes to bring all you together. It feels easy because we just join, but you can imagine how much effort Dr. Sajjad has put on talking to the speakers, to conveying messages, getting the flyer out. So this takes a lot of personal time. I mean, this is all personal time. We are meeting on Sunday. But what I'm happy and enthusiastic about is I think these activities we learn, and I use this term a lot, is subconscious learning. We are learning, we are creating a culture of learning, we are promoting. If we keep doing it, it will have positive impact. And that's why I load these lectures on the YouTube channel. I use YouTube channel as a storage repository. And because of that, I think anyone can access those lectures even like a year or 2 years down the road. And I will close here. And thank you once again. I think Dr.
Can I make one point, Dr. Safdar?
Yes, please go ahead.
Yeah, it was given. Yeah, it was given in the flyer as well that all those who participated in the conference, if they want a certificate of participation, they can email to Dr. Naila Nizami. Her email address and mobile phone number is given in the brochure. And I think Naila wants to say something as well.
Sure.
Yes, sir, I just want to add, I just wanted to request you that if as I have made a list, how will we hand over these certificates? Are these e-certificates? Just let the people know.
Yes, we can create digital certificate and we will send it to them.
it is all over the world in all the conferences that participant join, come up. So this is not. I mean, okay, but the point is that it is went very well, and I think it is a nice effort. Safdar and Sajjad bhai, is a very nice effort.
Okay, thank you all. I think we can call it a day then.
Thank you very much.
Thank you very much.
Thanks.
Thank you, Dalal.
To everyone.